Ma'am, you're good to go.
Good evening, everyone. I'm Dr. Usha Sriram from Chennai, and welcome to the 10th anniversary edition of Diwas program. I cannot believe it's already 10 years. So there are three important things happening right now. One is we are right in the middle of the global week of action for NCDs. So I think it's very relevant that we are talking about gestational diabetes as the mother of NCDs. And like I said, the second important thing is that this is the 10th anniversary of the birth of Diwas. We started as women to women, and then we thought that our mission should be in the name, and Divas also means women, and it is just and an acronym for diabetes and women awareness and advocacy strategy. So this is the 10th anniversary, and people like Professor Sarita Bajaj, Professor Seshia, Professor Padma Menon, and so many who are here were actually at the launch meeting, which so I'm so grateful that we are all here back after 10 years, and a lot of good work has been done by Divas in the space of women and diabetes, and we hope to do more in the space of gestational diabetes as well. So this is an incredible moment for us, and we chose to have the theme as gestational diabetes, mother of NCDs, also because post-COVID, we've been seeing a lot of NCDs in women, and we also are seeing an increase in gestational diabetes and the risk factors for gestational diabetes particularly. So this is the most opportune time to discuss this topic in great depth. And we have an amazing program this evening and half of tomorrow. But to set the stage, we have none other than Professor Seshaya and Professor Sarita Bajaj. And I would invite the event organizers to have the invocation and the lamp lighting by these two stalwarts. And then I will introduce them and they will tell us about GDM in India.
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you, Stuti. The third reason why we are very excited about this time is a day after tomorrow is Ganesh Chaturthi. I'm a big fan of Ganesha and a big follower. And also we have some big initiatives that we plan to roll out right after Ganesh Chaturthi. One of them is our program called Yuvadi, about which I will talk later in the program. But it is my honor to invite both the stalwarts, Professor Seshia and Professor Sarita Bajaj, Professor Seshaya is the honorary distinguished professor of the Tamil Nadu Dr. MGR Medical University for life. But he is also the founder of the diabetology department of my alma mater, Madras Medical College. He retired as professor of medicine and diabetology from there, and then set up and was in private practice, set up his great institute. But nothing compares to the pioneering and seminal work he has done in the field of gestational diabetes. The founder of DIPSI, and has contributed so immensely. More importantly, he has made an entire generation and the next generation recognize the importance of GDM, and encouraged all of us and brought us into the tent, encouraged all of us to work in the space, and he continues to be that beacon and that North Star we all follow. So thank you, sir, for doing all this great work. Professor Sarita Bajaj is the first president of Diwas. She was the president of Women to Women, and then the first president of Diwas. And what can I say about Sarita except she's a force of nature, and such an active champion for endocrinology, for women's health, for diabetology, and now she's brought this entire Southeast Asia or South Asia group together in the fight against diabetes, and the SAFES group, the South Asian Federation of Endocrine Societies, and in everything that she takes an active part. Most recently, she's the president of the Indian Thyroid Society, and I don't think there has been this much activity in any society except this past year in the Thyroid Society. And Sarita practices endocrinology in Allahabad. So both of you, please take over and enlighten us about GDM in India.
Dr. Seshia, you are mute.
You want me to speak? Dr. Sarita?
Yes, sir.
Yes,
Yes,
please.
you can.
Yeah, I'm very happy to participate in this conference. Usha Sriram called me about 2 months ago to participate. And I'm very happy that Dr. Sarita Bajaj is going to speak along with me. I wish she speaks earlier than me. Anyway, she says you speak. Okay. Now, this is a topic, 6 minutes they're given to me. I'll use 6 slides and see what we're going to do. But what I'm thinking now, so this diabetes and pregnancy, in this concept of what do you call that, GDM is non-linked diseases, has been there for the past years. See, first time we used the terminology in January in Usha's meeting when this started. GDM is mother of non-communicable diseases. Now, in this conference, I have to take some points which need the people still working or confusing what they should do. Now let me see few slides because I thought I'm too old to speak without any slide. Now you'll see the slide now. Diagnostic criterion studies used for estimating hyperglycemia in pregnancy. Now number of people talking. I am speaking Carpenter question. I know I would like to have WHO. I would like to IDPG. I would like to DIPSI. So let us see what we can follow. This is what happened. This is it from IDF Atlas. Now look at this. NDG, USA, and another thing, this is in same country, in the United States, the two groups. ADA follows IDF criteria, whereas ACOG follows NAD criteria or even carbon reduction. So within the one country itself, such a division is there. So let me see here. Then then the carbon reduction 2 over 8.6 millimole, that is 155. And the CDA, this is what happened. Canadian associations poly 9 millimole, that is 160 over 0.2. When it comes to again IDPG, it will be 1.75, and when it comes to DIPSI, it is 1.5. So there's no uniformity in the world. Every country follows different. Within one country, including India, people don't follow same guidelines. There's a number of things going on. So we want a uniformity, what we should follow. As that's what probably Usha is trying to make an attempt to see that everybody follows only one guidelines. So here, now I will love this international IDPG criteria, but there's got a problem here. International Association of Diabetes Pregnancy Study Group. I was one of the, actually I was vice chair, but now I have left that place. Guidelines are based on hyperglycemia and adverse pregnancy outcome that we have for study, which include only Caucasian population except city of Bangkok and Hong Kong. So it is obvious it is not people not involved other part of the world, mostly non-Caucasian not involved in the study. So that is one biggest drawback. Now what happened here? This is a boy, is a great friend of mine. He has come to Chennai number of times, India number of times. What happened? He realized what is happening in the world. He himself has recently commented that even at centers that accepted IIT recommendation, the approach varies and needs revision for standardization of the strategy for diagnosing GDM. So this is very, very honest statement he has himself made, who is the author of the guidelines of the IIT. So we leave it like that. Now that fortunately, Minister of Health, Government of India is following the guidelines here. That is the diagnosis and management of this diabetes mellitus. That's what we call it. DIPSI is following these guidelines. So IDPG guidelines is there, but in our country we are following mostly DIPSI, but still some people who want to do IDPG, but I told you previously, it is little problematic. So I would like again share one more information. Terminology for glycemic triadependence. Terminology for glycemia. So here, some people use diabetes in early pregnancy. So how can we call it diabetes in early pregnancy without knowing, unless it's a pre-GDM or non-diabetes? So the terminology for this, I think it should not be used. But now I see some paper diabetes early pregnancy, and some group call this as EGDM, early gestation diabetes mellitus. How can you give early gestation diabetes mellitus unless you diagnose GDM? It's only abnormal. So correct terminology is will be here EGI, early gestation glucose intolerance. We don't call them, unless you are sure about diabetes, you just call them early gestational glucose intolerance. That's what we are using now. Probably in DIPSI we will introduce this shortly. I am sure Yosha also will be able to realize that why I am telling this here. I have known people working in North India, Yosha, that Bharati Kalra. Antenatal women and relatives won't be scared when this terminology is given, because some place they said when a woman diagnosed diabetes, but GDM, she is scared and ladies are also scared. So the better to use the terminology is very safe for the person and as well as for the relative, that is early gestation glucose intolerance. Of course, nowadays we have started using very early screening for GDM, even 8th week, 9th week, we started using 8th week itself. Okay, this is what I want to share. Now, this is what I think my suggestion is, please use irritable EGI as a early gestation. In case we find out only the intolerance, you still not diagnose GDM. It's only intolerance. So GDM is the mother of NCD. How to prevent the development of GDM? That is what we are working. I would like to share with you what we should do probably the next time. By next year, we will have lots of data At present, GDM is the mother of NCD and how to prevent the development of GDM. That's what it should do. How to prevent GDM? So that we must target like clinical significant factors like prediction of GDM at which week. That is what we are working on that. You must also follow this prediction of GDM at which week you predict. And then I'm doing here because future this woman may develop diabetes if the blood sugar is like that in the early weeks. That is prediction. I'm not going to detail because time given is only 7 minutes. So this is what we use, prediction of GDM at which week we all should work. Glycemic criteria for prediction of GDM. Another thing is prediction of GDM and glycemic criteria for prediction of GDM. Both you must have. One, what week you must GDM will manifest, and what would be the blood sugar level at that particular time. Both have to be worked. We have worked, but now I'm not going to discuss that topic here, but I would like to share. This is going to be future. Now that's because Usha is probably very active in organizing meeting. Next time we'll see. So we'll talk about prediction of GDM. Which week? Glycemic criteria for prediction of GDM. And another thing also here, at which week metformin can be initiated. This again big confusion. They will say metformin cannot be given this and what time, what week given, safety, all this as well. But I'm telling you now, though I have put here, I have already worked on that. I know the answer. Prediction of GDM at which week is at 10th week. Glycemic criteria for prediction of GDM is 110 milligram at 10th week. And at which metformin can be used is after 8th week, because the 8th week all things are settled down, organogenesis is over, so you can use it. This is the basic information I am sharing with you, but probably next time when Joshua calls me, I will go in much more detail about this particular topic. And then prediction, intervention, and prevention. That is what we should do. Prediction, intervention, and prevention. So finally, within the given time, TAR starts in utero, the ends for diabetes pre-generation. Another acronym will be here, focus on the fetus for the future. Like GDM is another of the NCD. This one is another thing I'm introducing, focus on the fetus for the future. My chairpersons and friends here, I given time I have to discuss only these few points I can share. I hope I get some other time and I can go more detail about this topic. Thank you very much for the opportunity given to me, Darusha and the team. Thank you.
Thank you so much, sir. You can take as much time anytime.
Not today.
Not today, but I'm saying you are most welcome to share your thoughts and views with us. Thank you so much. Thank you so much, sir.
I will definitely do it. I was working, almost coming to the conclusion now in a month or two. We'll again go back to the how this particular concept, what I'm going to, I must have proof. I have done the proof. Now it is now 32 weeks now. So once delivery over, then I will open up the what is happening, how we are going to go out in the country. So India will be the lead. Now, as a matter of India, 22 countries accepting the Indian currency. So probably I will see that this currency will work everywhere now. Thank you very much, Usha, for opportunity.
Thank you, sir. Thank you. Thank you. Sarita?
Ma'am, you have to unmute.
Yeah, I've unmuted. I'll just start sharing my screen. Thank you, Usha, for the invitation. It's been a pleasure to be part of all your meetings for the last decade. So what I thought I would share the incredible journey as from my perspective and part of it which we have been dealing with together. Is my screen visible? And of course, I hope I'm audible. Is it visible? Everything is good?
Yes, ma'am.
Right.
Yes.
This is now, I think, slideshow format. So this is the 10th meeting. Decade has passed by. I don't think there's any diabetes meeting in which numbers are not mentioned. But I think everybody is aware of the fact that the prevalence of diabetes is increasing, and as is predicted, it will continue to rise. I think undoubtedly it's a huge problem in women. 537 people of these 537 million with diabetes, almost half of these are women. And the majority of this increase will be seen in middle to low income countries. And I think the highest rise is predicted in India. As far as the continent is concerned, I think Africa is also one that is being increasingly affected. 55% of diabetes deaths occur in women. It is the 9th leading cause of death in women globally. Why are these differences there? That is the higher morbidity, mortality, more of complications, 40% more risk of heart disease, and it is more neglected as well. So the focus in today's meeting is gestational diabetes, which is the mother of all NCDs. The global prevalence is shown here at 16.7%. That is hyperglycemia in pregnancy, which will cover any, whether it's gestational diabetes or pre-gestational diabetes. And the highest prevalence is in the Southeast Asian area. As you can see, if you look at the age-adjusted prevalence, it is a whopping 28%. So like I said, I would share the journey that Usha and I have experienced over the last decade. Tell you a little bit about the work that I have focused on in gestational diabetes. So this is our data from our state, that is Uttar Pradesh, in which we had about almost 2,500 women who participated, and the prevalence was 11.3%. Gestational glucose intolerance was 23.4%, and the average body mass index was about 24, which is obese. When we did the bivariate analysis, the risk factors found to be significantly associated were age, socioeconomic status, the educational level, pre-pregnancy weight and body mass index, the weight gain, family history of diabetes or hypertension, and the past history of gestational diabetes. In the multivariate analysis, only the upper middle category had a significantly higher association with gestational diabetes. So this is the map of Uttar Pradesh, and you can see the spread all across the state, ranging from 10.9% to almost 14%. Like Usha said, we started off in women in endocrinology and diabetes, and that was Wendy way back in 2011. Then moved on to women. And the slogan that was very interesting, diabetes no more, was the slogan that was adopted. Subsequently, when the Women to Women initiative, we were trying to sensitize women physicians, and the idea was to sensitize about 40 lakh women over the course of the year. There were 25 national site leaders, faculty, and module presenters. As you can see, Allahabad was also on the map of the Women to Women program. We did 24 programs. We tried to sensitize about 1,000 women. Then women and diabetes are right to a healthy future was the theme of IDF, the year I was president of RSSDI. So RSSDI and Diwas joined hands, and all the state chapters were involved, and a lot of activities were carried out, as you can see. While in RSSDI, there were several publications, the spoken word, and 2017 was the World Diabetes Day, in which I said women and diabetes are right to a healthy future. And the slogan was act today to change tomorrow, on this World Diabetes Day and beyond. So this is one of the meetings that we had in Chennai. You can see Faria is with us from Bangladesh. Of course, Usha and myself are also there. Usha mentioned the South Asian Federation of Endocrine Societies, which was formed as a society of Bangladesh, Nepal, Sri Lanka, India, and Pakistan. It's exactly a decade old too. The first meeting was held in Sri Lanka. And then we decided to focus on gestational diabetes. And we came out with the Dhaka Declaration. And the term was 2015 to 17. And the recommendations, the declaration, it was released in Lahore in November 2017. Now, there are specific challenges which are faced by South Asian children, apart from the child marriage, medical complications, problems from society and families, lack of preconception care, scant economic resources, delay in seeking care, the social taboo, and women, we know, constitute a large number of the illiterate population, and there's very difficult access to support services. Males have better access to healthcare, nutrition, and education. So on one hand, we have in the urban area, we have obesity, but we are still battling with the malnourished mother. So both ends of the spectrum are very harmful from the gestational diabetes perspective. So these are the publications which I have come out with: endocrine disorders during pregnancy, diabetes in women's health, diabetes mellitus issues for the Indian woman, and the RSSDI textbook, again focusing on women's health, management of diabetes and its complications. Then the Journal of Pakistan Medical Association invited me to write an editorial on women and diabetes. So what are we trying to do? Basically, educate women, risk factor modification, appropriate screening, and reducing the time to treat. How can we go about that? What is the solution? Healthy babies would lead to healthy girls, healthy women, healthy mothers, and that should be the circle we should adopt. And good health begins with good preconception care, improved access to screening, care, and education. Women are the real architects of society, and I'm sure the deliberations over the next day and a half will be very productive. Thank you. Thank you, Usha. Thank you very much. And of course, a happy birthday to Diwas. There it is, 10 years and soaring. Flying.
Thank you so
much. Thank you.
Yeah.
Thank you so much.
Thank you, Sarita. I mean, your talk just brought back such, great memories, fond memories. And, with Wendy and all of that we started with. And, so much so that every conference now in India and internationally, there is, always a session on women and diabetes. And there's such a focus on that. And I think it's an extraordinary effort on your part. And thank you so much for being part of this and staying with us throughout. Thank you, Sarita.
Not without a team. It's always a team. I think that is the most important. Thank you. Thank you.
Moving on, I was supposed to make a small presentation on GDM in numbers, but what I'll do is just talk about it for like 2 minutes, and then we go on straight to Professor Hurst's keynote address. So what I wanted to say was the current numbers are really disturbing, because there's like 20 million women who develop gestational diabetes every year globally, which makes it about 100 million women in 5 years. And each of these women gives birth to a baby, or occasionally to two, and they are at risk for diabetes and cardiovascular disease and obesity and other complications we are now understanding. So we're talking about, 200 million people who are at risk for future diabetes. And if you just multiply this by just, 10 years instead of 5 years, we're talking about nearly 500 million people, right? And so, those are the kind of numbers that we are, dealing with. And within India, and as Sarita has shown, on an average in the, urban areas, it's somewhere in the ballpark of 15 to 20%, and in some cities much higher, depending on whether it's a, infertility based, assisted reproduction based practice, or it's a, regular OBGYN practice. And then in the rural areas, somewhere in the, ballpark of around 9 to 10%. So these are incredibly high numbers. And because we have about 25 million babies that are being born every year in India, this is more than the population of Sri Lanka, and I think even the population of Australia. So those are the kind of, when I said GDM in numbers, what I meant was we have very large numbers. And even if 10% or 20% of the pregnant women, the mothers, develop gestational diabetes, we're talking, huge numbers again. 10% of 25 million is, we know is a phenomenal number, 10, 20%. So, and this just keeps adding on, and the next pregnancy and the next pregnancy, and 50 to 60% of them may have a, recurrence of GDM, and 50 to 70% may develop type 2 diabetes in the next 5 to 10 years after the index pregnancy. And this in addition to almost, twice the incidence of things like pregnancy-induced hypertension, twice the incidence of preeclampsia, and then C-section rates like 2.5 times. So these are numbers that are, again, like I said, very disturbing, and we need to aggressively do something. And I think the solution is what Professor Seshaya has alluded to, that is prevention of gestational diabetes. As I heard someone say, the best way to manage diabetes is to not get it. So if we should not get diabetes, I think we should focus on preconception care, focus on pregnant women, that they have babies that are born, optimum birth weight, and children are not overweight or obese, and they eat healthy and are active, and same for adolescents. And good preconception care is done for women before they get pregnant, and early screening, and following protocols during pregnancy, encouraging breastfeeding, and then follow-up testing of GDM women, and then also following them, taking a life course approach. And that exactly is what Professor Jane Hurst is going to talk to us about. So with that, I will move on to introducing Professor Hurst. Can I have those slides, please? So Professor Hurst would speak on pregnancy as a window to future chronic disease. She has just taken on the appointment as clinical chair in Global Women's Health at the George Institute, UK, in the School of Public Health. She will lead the George Institute Global Women's Health program, focused on improving women's health throughout life and championing evidence-informed approach to addressing the leading causes of death and disability worldwide, mainly non-communicable diseases. Professor Hurst is, professor of obstetrics and gynecology at Oxford, and leads multiple initiatives like the Smart Health Program in India, China, Vietnam, and other places, and has been involved in some pioneering work in the space of following up of women post-gestational diabetes. So this is a the Smart Health for Pregnancy, as I mentioned, improving women's lifelong health in especially rural India, the Intergrowth 21st program, and the Oxford Maternal and Prenatal Health that's in the Institute. So I'm so grateful that Professor Hurst has kindly consented to deliver the keynote address. Jane?
Thank you. I'm just going to share my screen. And just slideshow. Okay. Is the slideshow showing correctly now?
Yes, ma'am.
Thank you. So thank you, Usha. It's an honor to be here today to talk to you all about the work which me and my team are doing. Thank you for the introduction. I guess now need to introduce myself, but just to reemphasize, my background is I come to the problem of gestational diabetes and pregnancy as an obstetrician originally, but I hope that I've been enlightened, and hope some of you are too, about how women's health is far more than reproductive health, and we need to see how we can use pregnancy as an opportunity to improve this. So let me just move slides. So declaration of it. So my funding comes from the UKRI and MRC and Wellcome Trust. And so where I'm starting with my work is this problem we're all trying to address. And this is that we know that during pregnancy, gestational diabetes is common. Hypertensive disorders of pregnancy are also common and sometimes co-occur. And these women are really marked out to be very high risk within the years immediately after birth of either getting type 2 diabetes or chronic hypertension. And we know these are the leading risk factors in women for premature cardiovascular diseases and death and morbidity, including stroke, ischemic heart disease, and chronic kidney disease. And really what we're trying to do is see whether we can break this link. So I'm sure many of you have seen this diagram before, and it just illustrates, sort of what the underlying hypothesis is. And we have a lot of observational data now to support this. And the idea is, here we're using hypertensive pregnancies, but you could easily have the same graph for gestational diabetes, is that if we have two women, one in the red, one in the black, one woman enters pregnancy, goes through her lifetime, and maybe when she's a lot older, in her 70s, 80s, she may develop a non-communicable disease. But there are other women in the red here who, when they become pregnant, suddenly an underlying predisposition is unmasked for a predisposition to cardiometabolic diseases. And what's important is if you look at the trajectory over time with that red line, after her first pregnancy where she had hypertension, if she doesn't go back to a baseline risk, and a second pregnancy exposes that again, and subsequently premature cardiometabolic diseases. So I guess the question, if we focus, back to diabetes and cardiometabolic diseases, can we prevent this? Like if we're picking this up. And tomorrow I'm going to talk a little bit more around the evidence, particularly the recent trial evidence and things for this and where we could go in the future. But I think we're all aware of lifestyle and diet interventions, breastfeeding, and the role potentially of some of the anti-diabetic medications. But there's a big question around these things, is when is the best time that these things should start? We've heard already, pregnancy hypertension and diabetes in India are big problems when we think of the scale of the number of pregnant women, but also in terms of the prevalence of the conditions. And I think the data on hypertension would suggest that about 1 in 10 pregnant women in India develop a hypertensive disorder of pregnancy, with about 3.8% developing preeclampsia. The national data on gestational diabetes is very variable, and I think there's a lot of heterogeneity in screening coverage and screening practices. And I think this paper from the NFHS4, I think where they diagnosed GDM, unique random capillary glucose, which I think we would all agree is not the optimal test for glucose, found rates are sort of much lower than we see in the more rigorous studies that have been done in other places. So I think a word of caution there, depending on what data you're looking at. I think these are gross underestimates. And so coming back to when is the right time for us to prevent future cardiometabolic disease? Well, I guess the real question I ask is, what about postnatal care? I mean, I'm an obstetrician. We traditionally care for women up to the time when the baby comes out. We might see them for 6 weeks later, but is this a window we could utilize? And these big groups, FIGO, WHO, Royal College of O&G, American Heart Association, American Diabetes Association, and local Indian chapters, I think all recognize this risk, and a lot of them have put out position statements about we should use the window of opportunity that we have. But the issue here is that the recommendations around exactly what that screening should be, who should do it, who should pay for it, when it should be done, how often it should be repeated. These things are generally fairly vague and poorly implemented as a result on the ground. And they're vague for a number of reasons. One is, I think that, the evidence in this space is not been great. We don't have randomized trials. It's mostly based on observational historic data. So a lot of work still to be done. The most well-researched area of this is, of course, type 2 diabetes screening following gestational diabetes. And even in the best resourced health systems in the world, the rates of follow-up screening for even just one postpartum follow-up are pretty poor. So what currently is in maternal postnatal care? I put this up I know there's a lot of diabetologists and endocrinologists in the group. What do the WHO actually say we should do? Well, last year they issued their guideline on maternal and newborn care for the postnatal period. And out of 63 recommendations, disappointingly, I think, other were around, ensuring, recovery from the birthing process itself, bleeding, infection, these things, contraception, and a little bit around the mental health of the woman, which is, of course, also all very important areas. Most of the big trials in the postnatal area have actually been on newborn care, and we have some great evidence, level A evidence around what we should be doing to prevent newborn deaths, but we don't have the same for women, and very little research, as I say, on the content and timing. I think in addition to this, I'd put out a plea there that there's a growing recognition internationally that the effects of pregnancy do not stop at 42 days or 6 weeks after birth. And nowhere is this clearer than, I guess, in the risk of diabetes and hypertension after pregnancies affected by GDM or preeclampsia, but also particularly in mental health, where suicide of women sadly is a fact, and that can happen, within the first year at least after the birth, still related to events in the pregnancy. So a growing plea to expand our definition. What about here in India? Well, I've been doing research with colleagues at the George Institute in India since 2016 around this area, and we're working in Telangana state and in Haryana. And I think as a foreigner, what I've sort of observed is very impressive and significant progress in reducing maternal mortality, and certainly a big push towards institutional delivery and improving quality of care. And this is supported by a number of high-profile government incentives and initiatives, which I think many of you will be very aware of. And I've got the picture here of the KCR kit in Telangana, which is also accompanied by a cash incentive payment for women delivering in government facilities. But from talking to a lot of people on the ground and specialists down to community health workers, I think that it's acknowledged that this whilst these benefits are certainly there at the macro level, at the micro level there are inequities, particularly around health worker shortage and equitable coverage of quality care, and a real problem which is common not just in India but in most health systems around the world is connecting levels of the health system together, and the ability to screen for high-risk conditions before women present with sort of end-stage complications or very advanced problems. So this is where I want to introduce the rest of the talk. I'll talk about an intervention which I've been part of with partners at the George Institute in India. And this is something to try and address some of these gaps that we have and really introduce a lifelong approach to women's healthcare. And it's based around this system called SMART Health, which stands for the Systematic Medical Appraisal, Referral and Treatment. And it was developed by the George Institute in, I think, 2012. So just over a decade ago. And the main objective of it was to improve cardiovascular risk factor screening for older adults living in rural communities across India. And it's since been expanded to several other conditions. You can see there: diabetes, TB, HIV, mental health. And the number I've got there is a little out of date. It's actually closer to double that now, 600,000 people screened. So a large number of people have been screened, not just in this country, but in other countries in the Asia region. What is Smart Health? Well, it's an intervention which is aimed to strengthen the health system across a number of levels. So strengthen firstly by introducing screening of high-risk patients by community health workers in their villages, in their communities, decision support, based on best evidence-based guidelines, put that in the hands of the community health workers, creating a secure digital record which the doctor can review, and importantly, the doctor can then share tasks back to the community health worker, such as ensuring medication compliance or diet and lifestyle compliance. Once the patient returns to their home, the patients can be sent self-care reminders, short little health promotional messages. And, this is all sort of within a framework that's supporting, change management, but having some accountability within the system as to what's happening and what's going on. And so I guess the question that the George Institute researchers came to me, as I say, around nearly 6 years ago now, was, they said, well, look, the community health workers, namely the ASHA workers and ANMs, they're really enjoying using this system, but their day job is actually looking after pregnant women and babies, and they were seeing complications in their pregnant women, and they were asking, can we use it for pregnancy to help improve detection of high-risk conditions? And so being an academic, myself and the group, we sort of looked to how we would develop an intervention, and we used the MRC framework to develop a complex intervention. And the first stage of this framework, although it's a cyclical thing, is really to identify the evidence and identify what you really want to do. So we spent some time doing this, and also establishing what's going to work and what's not going to work and what we've tried before and things. So really listening was our first activity here. And so we did a number of literature reviews, but also listening activities. And then we also conducted some stakeholder events, both at sort of national level with leaders in women's health and non-communicable diseases, as well as down at sort of community level, talking to ASHA workers and women themselves to find out what really matters. And what we found from this very important foundational stage was, when we listened to what people were saying, particularly from rural communities, is really in pregnancy, the number one priority for them and the number one major challenge they was facing was anemia. So whilst they all acknowledged that hypertension was a problem too, and in the rural settings where we were actually screening for gestational diabetes wasn't actually happening at all. So they thought they had zero gestational diabetes because they were doing zero screening, which I think is not an uncommon problem, in many places around the world. But really something had to be thought about with anemia. And what was also clear was anemia is not just a pregnancy problem. This is a problem that actually affects women throughout their lives, and particularly, as we know, menstruation, losses of blood at childbirth and things, combined with the usual risk factors for anemia are a real problem. There was an acknowledgement and recognition that women's health needed to be life course approach. and the detection and management of high-risk pregnancies needed to be better. I think particularly doctors working at referral hospitals, it's very disheartening to us to get patients who really advanced with either diabetes or preeclampsia or anemia, and a bad outcome may be inevitable in that case because we've had no chance for prevention. Everyone also acknowledged that postpartum care was very neglected, and for most of the high risk cases, postnatal follow up was absent. So we developed on the back of the Smart Health model this thing we call Smart Health Pregnancy to integrate pregnancy care with NCD and anemia prevention. And you can see here the steps as we go around the circle. So we start with an education program for the community health workers. And this education program is really key because remember, concepts like gestational diabetes are not just foreign to many of the women in the society. Spend the education program focuses on educating about the high risk conditions, educating about how to do point of care testing using devices recommended by the government of India for community-based screening for anemia, for blood sugar, for blood pressure as well, and then training on how to use the app to enter this data and see the risk support. So once they've been trained, they then go and identify women within their village and register them on the tablet app early in pregnancy. They do screening throughout the pregnancy for these conditions based on a schedule which is supporting the antenatal care program in India. They enter the data on the app, and then a risk decision support and recommendation is displayed. And then this, if required, they are referred to the primary care doctor for review, and that doctor also has a tablet app which will show him or her the recommended management of those conditions, so standardizing care at the PHC level or recommendation for referral on to secondary care if needed. And what is, I guess, the sort of unique selling point or USP of our program is that we've designed it that it doesn't stop as soon as the baby's out. We've designed it that this screening keeps going for up to a year after birth. And I guess if I had unlimited funding and unlimited support, it would be a lifelong thing for women who are detected to be high risk. But at the moment, it's 1 year. So this is what it looks like. The app is very, I guess, fairly basic. It's pretty simple to use. This is an ASHA worker screening a woman in practice. The data on the screen is just made up data. It's not this woman's data, but it gives you an idea of what it looks like. It's, of course, available in local language, so in Telugu, in Siddipet district, and up in the north in Hindi. And so the ASHA worker, which is trained how to take blood pressure properly, so you can see the woman sitting comfortably with both feet on the floor. She's putting the cuff in the right spot, and then she enters the number into the app, which green dot means good, and she can see a graph if she would like. She then does a finger stick HB test and similarly enters that into the app. And at the end of the process, there's a recommendation for what needs to happen. So if you click on the red areas, it'll say that, say for this woman that she needs to go and have either her tetanus or deworming, and the high risk condition's been detected, so she should be referred on for medical assessment, and that she, in this case, had high blood sugar. So this is what we're doing. So we then went on to pilot this, and so we have published this data now on our pilot trial that we did. And the pilot trial was done during 2019 to 2020. And as we all know, 2020, something else happened during that year, namely COVID. But we were aiming to determine feasibility and acceptability, and we did it in these districts as listed here. So in this small stage, we only had 200 women across 4 PHC clusters. We recruited them before 28 weeks, and for this pilot phase, we only followed to 6 weeks postpartum because we needed to just demonstrate the feasibility and acceptability with the community health workers and women. And they were screened in this stage on 4 occasions. And what did we find? Well, we found that acceptability and feasibility was very high. They used the app very well. And from the qualitative interviews, everyone felt this was a valuable initiative, which was reassuring. Surprisingly to me, and I think to the rest of the team, the rates of GDM and hypertension we picked up in those 200 women were a lot lower than we had expected. We were expecting about 10% overall, and actually it was about 4%. This may be due, again, whilst we were trying to improve the screening process, I guess it's still possible that we were recruiting sort of at 28 weeks, perhaps women were missing their GTT, or the procedure was not done, by the book. But it was nonetheless a little bit lower. But what was high, and I think quite shockingly in a way high, were actually the rates of anemia in these rural communities we were seeing. So out of the 200 women, only 21% of them had no anemia. And you can see here, moderate and severe is over 50% of these women. So bringing home again, that when we want to introduce interventions or develop them, we need to be addressing, what is the real burden of disease on the ground. So whilst obviously GDM and hypertension are important in that small group of women we've identified, a much larger group are affected by these conditions. So we now have moved on after that very informative work to evaluating our intervention as to really can it do what we want it to do, and trying to think of implementation and scale up. So recently we published the protocol trial for the Smart Health Pregnancy trial we're doing at the moment, and that's available in Trials if anyone's interested in reading it. And the primary research questions we want to ask are twofold. One, does it work? So effectiveness. And specifically when I say work, what we're trying to do is decrease the prevalence of anemia in these communities at 1 year after birth by 9%, and improve follow-up after a pregnancy affected by diabetes or hypertension. So 2 co-primary outcomes there. Secondly, how can we implement it? So we're measuring implementation using a framework called REAIM, which measures how well we're reaching people across the communities, who's being left out, who's being included in, how effective is it, how well is it adopted and normalized into the health system, how is it implemented, and how is it going to be sustained? So, as I say, both very important when we're thinking beyond a trial situation. So our trial design is what's called a type 2 hybrid effectiveness cluster randomized trial. So type 2 means that we're looking at effectiveness and implementation at the same time. A cluster trial means that we randomize primary healthcare clusters rather than individual women, because if you think about this intervention, it's really acting at a health system level to improve that connection between the community health workers, the women, the primary healthcare doctors. So an individual trial was deemed not suitable. We're now working across 3 districts listed there, and we've got 30 clusters and 60 villages that we have recruited 240 community health workers, and we're aiming to recruit 3,400 women. And so what does the pregnancy look like? Well, and so the Smart Health Pregnancy trial look like? Well, we basically are comparing 2 groups. One is the enhanced usual care group, and one is the intervention group. So the enhanced usual care group are essentially women are being recruited after 12 weeks of pregnancy, and they're having standard antenatal care. It's enhanced because we're actually in those sites trying to help them to do some glucose screening, because otherwise we're going to face a massive bias in that we're only going to find gestational diabetes cases in our intervention site, and it'll be none in the control site essentially if there's no screening there already. So it's enhanced because we have done some capacity development and building to enable that to happen. And then the women will have their standard postnatal care for 6 weeks. They'll have a study assessment to collect some birth outcomes at that time, and then basically they just have care for the baby as per the schedule for immunizations in India. And then they'll have an assessment at 12 months after birth. In the intervention arm, what we're doing is, in addition to having standard care, they're having additional visits throughout the pregnancy to screen, for the high-risk conditions and be referred and treated. And then crucially, this continues after birth and is tied in with the timing of the immunization schedule. So there's a point in those women's lives when they're going to be interacting with the health system. And as you can see here, the activities in the intervention clusters, as I described before, the education program, the app, there's a dashboard so we can keep the PHC doctors can keep an eye on how many cases they've got. We're also doing some supply chain monitoring to make sure that essential drugs and equipment are available, and throughout, doing regular stakeholder engagement and the usual care clusters, as I say, usual care. As I mentioned, we are also measuring the process analysis to measure our implementation outcomes. So where are we so far? So we're making great progress. We started in June last year, and everyone's onboarded and trained. We've nearly, got to our recruitment target. So as of the end of last month, we're at 2,800 women recruited. I think we'll finish recruitment by November. And we're already starting our refresher trainings every 6 months and doing interviews with the health workers to see how things are going. So we anticipate this trial will be completed by early 2025. Remember, there is quite a long follow-up after recruitment for the women, and so really watch this space as to whether can we show this to be a feasible model for a low risk contact of care. In parallel with the main trial, we've had some really important and I think impactful new developments. Firstly, we've got funding from the Gates Foundation to incorporate a ChatGPT chatbot function into the app to support the community health workers and women in the field. And what this is going to be based on is Indian guidelines for diet, lifestyle, pregnancy management as appropriate for community health worker level, and it really will provide a way to strengthen the knowledge that is available to people, and this is available in local language. And ideally, we're going to develop it to be available speech to speech in local language, not just text to text. We're also in parallel developing or co-developing with partners at NIMHANS a perinatal mental health support module and something to reduce stigma around mental health, and a continuous learning and supportive supervision module, because I think if this is to be scaled across a district, a state, a nation, we have to think carefully about how we're going to actually continuously support health workers to deliver this intervention as we go forward. The newspaper clipping down there, that's just a selection of one of the ones we had from our recent visit earlier in the week out to our partners at PGIMS in Rohtak, Haryana, where we have great support from the Vice Chancellor and her team there to implement this intervention. So in conclusion, my take-home messages for you all today are pregnancy conditions can and do have lifelong consequences for women, and the first step in prevention is recognition and screening. After birth, as we know, attention always shifts to the baby from both the family, the woman, the health providers, and maternal postnatal care as a And we also need good evidence on how to bridge secondary and primary care for this lifelong prevention, providing care that's timely and convenient for the women themselves and their families. So expecting them to come back to a secondary or tertiary care hospital for a GTT, we know that doesn't work. So we need to think of new models to do this. And I think digital solutions really have a potential role to fill these gaps. However, they need to be properly supported, resourced, and implemented and developed with community and health systems in mind. So with that, here's some pictures of my team and the ASHA workers involved, and I'll stop there. Thank you.
Well, thank you, Jane. This is just incredible work. Thank you so much, both for your work and for this presentation. Maybe we can take about 5 minutes for some questions, if anyone has any for you. So can I start the ball rolling? You said all ASHA workers have been trained. So how did you do that in terms of training all of them?
Good question. Yeah, so the ASHA worker training is really fundamental to this because, you know, they're coming from a fairly low base in that their current ASHA worker training doesn't address these conditions at all. And it's not actually seen as an ASHA worker job. It's more A&M or PhD doctor. So the training at present is an in-person training. It's a 3 half-day sessions, the first on the conditions, the second on how to screen, and the third on how to enter the data into the app. But I've got a PhD student who's working very closely with the ASHA workers to try and develop a sort of more continuous and hybrid model of training that would be easier to scale out. So using, you know, maybe WhatsApp, YouTube videos, the chatbot will be part of this as well. How we can, you know, provide support to people in maybe a less intensive hands-on way. But I think, you know, we have to acknowledge that some investment is needed up front there. And the worst thing that happens is, you know, someone just goes out to a clinic and either just hands out the tablets or smartphones and says, use these, because we know that doesn't work. You know, people do need to understand what they're doing, why they're doing it, and then you get very good engagement.
Yeah, thank you.
Usha, Preeti here.
Yes, Preeti?
Yeah. Jane, how do you assess that their understanding has been complete, and is there a way of assessing their education level, that they have reached to the optimum which you require?
Yeah, no, good question again. So we do like pre-test and post-test assessments, and clearly post-test, you know, everyone's knowledge has gone up. But as we know in adult education, you know, if you ask me probably tonight what I've learned in the conference today, I'll probably remember a lot, and then probably tomorrow or next week I probably will have forgotten it all. So what's really important is actually then observing how they do these things in the community, and having that sort of closing the loop as to do they do the testing correctly? Do they know how to do things properly? So we are assessing that as part of the trial. You know, we have a checklist of the steps they should be doing. And then, as I say, we have a refresher training at the moment every 6 months, which I think is also important to touch base, because remember also some people come in and out of the program, or they've been off for maternity leave, or they missed the training on one day. So we need to make sure that there's a continuous support mechanism in place, because if it's just a one-off, it'll have a short-term splash, but probably the ripples won't go very far. So we need to keep the training going.
Can I have a question, please? Jen, I like your work and very good work which is done. But the reason for that 4% of GDM which you see is the age difference. You see, in cities, most of them get pregnant after the age of 28, 29, 30. So we get a much higher percentage of GDM as compared to villages where the marriage is still little early and they have pregnancies, earlier pregnancies also. And the nutrition also matters. And these two things, for example, I started working in diabetes since 1972, and I used to see 1 or 2 GDMs per year. It was very, very less, I should say, and that was in Kenya, Nair Hospital. It's a municipal hospital where the drainage was quite good, and our OPD used to be 100 odd patients of diabetes. Type 2 diabetes seen after the age of 35, we start wondering, are we missing any secondary causes? To that extent, the diabetes was not. So with increasing incidence in diabetes, I think the incidence would go up, the prevalence would go up. And that is why you see them 4% there, whereas in villages, in our cities, it will be easily 15 to 16% as shown in the data.
Yeah, that point is very well made, and you know, in our pilot study, the sort of age was, you know, so 18 to 21 was the most common age bracket.
Yes.
What we do see in Haryana is, you know, that where, you know, there is sadly a very strong preference for boy child, as there are some people who are coming back having 3, 4, 5 children, you know, trying to have the boy sort of thing, you know. Yes. I mean, I'm just saying as it is. I'm not. This is the reality.
No, we understand.
On the ground there. So there are a cohort of some older relatively older, I must say, women coming through. But there is a lot of pressure, I think, to start marriage and childbearing quite young in these populations. And a lot of the women are probably more still on that malnourished or underweight side than actually on what we see in the cities where people are getting, the dietary transition and things and getting bigger. So I think this is why anemia is really coming out as the strongest risk factor that we're finding in this group so far. But when we have all the data from the big study, it'll be interesting to see how that plays out.
And we also have pregnancies which are, IVFs and things like that in the city population, which is not seen in the village.
No.
Well, thank you so much, Jane. And we probably will have more questions for you at the end of the day or at your next session. So we move on to session 2, and I'd like to introduce my colleague, Dr. Amala Florida, who's a diabetologist working at both VHS and also at the MV Hospital in Roypuram. Amala, take over, please.
Thank you, ma'am. So the next session of the day is going to be drivers of GDM. So to moderate this session, we have Dr. Krishna Prashanti and Dr. Sampath Kumari with us. Dr. Krishna Prashanti is Senior Consultant Physician, Hashita Hospital and Best Diabetic Care Center, Tirupati. She is also Chairman-elect of the Andhra Pradesh State Chapter of API. Professor Dr. Sampath Kumari, she's currently Professor of Muthukumaran Medical College and Research Institute. She's also Vice President of Foxy South. Over to you, ma'am.
Thank you very much. Dr. Sampath Kumari, madam is here.
She may be traveling.
She has not yet logged in.
Yeah. Okay. First of all, I extend my heartfelt thanks to Dr. Usha Sriram madam for her untiring efforts for bringing all of us together on this very important platform. And we are proud to celebrate the 10th year of Diwas. And today our session is a very important session because our patron, our father, Dr. V. Seshaya sir has started the session, and he's the father of the GDM. And now we have to understand what are the drivers of the GDM. In this session, we are having the eminent speakers, particularly Dr. Mala Dharmalingam madam from the state of Karnataka, who needs no introduction, a wonderful speaker and a wonderful clinician. She is going to speak on pre-diabetes in women of reproductive age. The clock starts ticking sooner. She is Senior Professor and Head of the Department of MS Ramaiah Medical College and Hospital. She is Director, Bangalore Endocrinology and Diabetes Research Center. To her credit, she has 12 awards, including the prestigious Dr. B.C. Rai Award, Epicon Vocational Excellence Award, MGR University Academic Excellence Award, and she is a very great researcher, clinician, and an excellent teacher. And we are going to hear a very important topic from her. Over to you, ma'am.
Thank you, Dr. Krishna Prashanti, for the introduction, and thanks, Usha, for the great meeting that you always have on. Otherwise, we women are delegated to background. So, give me a minute.
Mala, may I just add one thing? Can I tell that
sure,
you spoke on this topic 10 years ago?
True.
In the first Diwas meeting. And we've come a full circle. Thank you so much. Yeah.
Thank you, Usha. So, yes, when I spoke of this topic about 10 years back, less was known about pre-diabetes. It was an exciting stage that we were in to see what is this pre-diabetes. And we have come 10 years and we have understood a little bit more about what it is. So I'll be talking about pre-diabetes and where are we as far as prevalence, what are the problems associated, and so on. So all of us know what is the definition, but just to recapitulate, ADA has impaired glucose tolerance between 140 and 199 post 75 grams OGTT as a definition of IGT, and IFG, which is between 100 and 125. While WHO has IFG at 110 to 125. But apparently, the ADA definition correlates better with the impaired glucose tolerance, and maybe more diagnosis will happen with the ADA criteria of impaired fasting glucose. And of course, we all know the HbA1c between 5.7 to 6.4 is pre-diabetes. So this slide, all of you have seen time and again. It is from IDF in 2017. And this is about pre-diabetes, not necessarily in reproductive age group, but in general, roughly what they have said in the Southeast Asian region, that we are about 3% in 2017 when this was published. And they said it would be about 3.7% in 2045. And the whole numbers were between 29.1 million and becomes 50 million after about 20 years. But I think we have surpassed all of that. And we are, as a nation, 100 million diabetes today. So when this is the ICMR in-diab population data, which was recently published this year. And if you can see here, I'll just use this pointer to see this. The women are in these violet squares. So just see where the line actually takes off. It takes off somewhere around 20, 22 years. It has diverged and it has increased, and it is going on increasing still about 45, 50 years, but sort of plateaus and then takes off again after 64 years. So definitely we are seeing pre-diabetes earlier, right around about 22, 23 years, and it is continuously increasing in the reproductive age group. So this is something that we are worried about, that it is starting so early and increasing. And we don't need these data. If you just look at your own clinics, where were we seeing diabetics, girls who are coming at 20 years, 18 years, so many of them come today with diabetes. So again, with this pre-diabetes in India, that is the ICMR in-diab trial, they said the overall prevalence of pre-diabetes was about 10.3% using the WHO criteria, or about 24% using the ADA criteria, because you know there was a 10 mg difference. And this is a huge number. And the worry is the conversion rate in our country is strangely very high compared to the rest of the world. And all of them are going to become diabetic very soon. Like I said, it progresses much faster in Asian Indians. They also said that it could basically be the insulin secretory defect, which is the pathogenetic factor in us Asians. If you look at the prevalence between the urban and the rural, they found that there was as much diabetes as pre-diabetes, 1:1 in urban areas. That means the conversion is so fast, while in the rural areas, the prevalence was 1:2. So possibly at that time, the conversion is not so much as the conversion in urban areas. So this was a very interesting study, which was just published recently in the American Journal of Preventive Medicine, where they looked at data between 2005 to 2018. And you can see here, this is premenopausal women, and in the dark gray, and continuously the prevalence is increasing in all the populations, just like it is in diagnosed diabetes and undiagnosed diabetes. So that's the concern, that all the pre-diabetes are going to convert to diabetes, and we are going to be in a big mess. So now the same study also said that in women of reproductive age, nearly 1 in 4 had pre-diabetes, and 5.2% had diagnosed diabetes, and 2.5% had undiagnosed diabetes. And they showed a prevalence of pre-diabetes rising from 20% in 2008 to 28% in 2018, an increase of 8%. And they said this is very high compared to diabetes, which was more gradually increasing compared to pre-diabetes. And what they also found was in premenopausal women, there was a strong association with obesity. Unlike those with normoglycemia, the obesity and central obesity was the odds ratio was almost 3 times. So 3 times increased risk of obesity, which is a comorbid condition, and today a disease by itself, which is called ABCD, adiposity-based chronic disorder. So the magnitude of association was more in pre-diabetes, and also in diabetes was in premenopausal women, was greater than age-matched men or postmenopausal women. They also found that the risk of hypertriglyceride was very much higher. So premenopausal women had increased, they concluded, had increased prediabetes and undiagnosed diabetes. And of course, we all know that this is not only conversion to diabetes, but a cardiovascular risk burden. And not only we have to understand that, but we should also start screening young and early middle-aged women for these complications and comorbid conditions. So what is the risk and who should you be screening? We all are again aware the age is 30 years. Earlier, we used to say 35 years. Now the age is 30 years greater than who are older than 30 years. BMI 35 kilograms per meter squared, first degree relative with diagnosis of diabetes, GDM, and who had a baby who was more than 9 pounds. Lifestyle is sedentary, hypertension, low HDL, high triglyceride, and signs of insulin resistance like acanthosis, polycystic ovaries, depression, and obstructive sleep apnea. These are all certain very important conditions or risk factors you should look for pre-diabetes. So why are we worried about pre-diabetes? We know that this translates to these complications in adolescents and slightly older women: overweight, obesity, polycystic ovarian disease, impaired glucose tolerance, and diabetes mellitus, hypertriglyceridemia, and metabolic syndrome and cardiovascular disease. So this was another very elegant study which looked at association of prediabetes with obesity, central obesity, hypercholesterolemia, hypertension, and hypertriglyceridemia. So look at this where they talk about prediabetes in premenopausal women, and this is the odds ratio. You can see that this line is more for premenopausal women compared to age-matched men or even postmenopausal women. So whether we are talking about obesity, central obesity, hypercholesterolemia, hypertension, or hypertriglyceridemia, maybe hypertriglyceridemia, the premenopausal women were less, but in every other condition association, it was more in premenopausal women. So polycystic ovaries is the best clinical guide you can take for exactly what happens in prediabetes and progression of the disease itself. So you can see as a young child, there is insulin resistance, premature adrenarche, precocity sometimes, weight excess, visceral adiposity, irregular menses, and other signs of hyperandrogenism and obesity and diabetes. And at that time, infertility and gestational diabetes are very important factors that set in. So this was a paper which said, this is a very simple term, which is called hypertriglyceridemia waste, HTGW phenotype. They said, we know that visceral adiposity is the main surrogate.
Recording
through
in
the high
progress.
penetration of these restaurants with serving fat-rich food. Obviously, these fat-rich food are more tasty. So that is why all adolescents prefer to have these kind of food. And apart from that, polycystic ovaries has its own problem of increased craving for other reasons why they consume more. The physical activity, again, more sedentary lifestyle. We have changed from the agricultural lifestyle to an urbanized lifestyle, and this is accompanied again by decreased physical activity, lot of reliance on automobiles, cell phones, and all of this leads to, and of course, TV watching cannot be missed, low levels of physical activity. So this was a very interesting study which looked at pregnancy outcomes. I know we do have some talks next about pregnancy in women with diabetes, But here I wanted to tell about pregnancy outcomes with IVF in patients with polycystic ovaries and PCO. The interesting thing is they divided the group into impaired fasting glucose and IGT. And surprisingly, the IGT fared much worse than IFG in all groups. So if you look at conception, IGT was lower than women with IFG, even after adjusting for age, BMI, infertility, testosterone, and treatment. And the interesting thing was that women with IFG had a higher rate of conception than women even with normoglycemia. This was very interesting to me. And then when I looked up, they have said some of the reasons, which I will discuss with you. So then the IGT had a higher rate of pregnancy loss and a lower rate of live births. And the risk of large for gestational age was also higher in women with IGT compared to IFG. So having an impaired fasting glucose of a higher fasting, they found was not so bad as having a higher postprandial hyperglycemia. And of course, small for gestational age was also more in IGT and especially preconception IGT compared to IFG. Women with IFG had a higher risk of gestational diabetes even after adjustment. So later they would become diabetic, but in the beginning, if they didn't, the risk seemed to be less. So preconception IGT was associated with lower rate of conception, higher rate of singleton pregnancy loss compared with IFG. And women with IFG had a higher rate of conception than normal. And the favorable effect of preconception IFG on conception and pregnancy loss seemed to be at least partly mediated through improving endometrial receptivity, though they said the exact mechanism is not known. So apparently in IFG, the endometrium receptivity for the egg fertilized egg was very good. They also found that the endometrial thickness was higher in women with IFG than women with IGT before the embryo transfer. Although both are intermediate states of abnormal regulation between normal glycemia and diabetes, IgE and IFG have different sites of insulin resistance. When they did a dynamic test of insulin action, IGT primarily is characterized by moderate to severe muscle insulin resistance and normal to slightly reduced hepatic insensitivity, while IFG mainly has hepatic insulin resistance. So there it was muscle, and here output and normal muscle insulin. Maybe this is something which caused them to have better outcomes. This is what they have hypothesized. So insulin promotes cellular and mitogenesis and endometrial proliferation during the proliferative phase and accelerates glucose uptake during the secretory phase. It is possible that the state of insulin sensitivity at the endometrium on ultrasound, but decreases in IGT. So that is why they found there was a difference with IFG and IGT. To summarize, the singleton and twin pregnancies, higher rate of singleton pregnancy losses compared with IFG, independent of BMI. So now how do we go about managing this? We all know it's lifestyle. We have to screen for the cardiovascular risk reduction, weight, blood pressure, lipids. Our goal is basically to prevent diabetes, fatty liver disease, excessive weight gain, and see that they have a functional and good quality of life. So if they're overweight, the goal is to reduce about 7 to 10%. You can give some medications or consider bariatric surgery if they are associated with some morbidity. But if it's not that severe, then you can address the insulin resistance with metformin, acarbose, and pioglitazone in PCO patients. But somehow pioglitazone is still not so much used except metformin. And if they're overtly diabetes, of course, we have to do their glycemic control. This is basically the pre-diabetes management algorithm. To summarize, whether the clock is ticking and it is happening earlier, yes, it is. the prevalence of prediabetes is increasing in women with reproductive age group. And there's a strong association of prediabetes and PCO and vice versa. Ratio of prediabetes are equalizing, prediabetes and diabetes are equalizing, showing a high diabetes conversion, and prevalence of prediabetic in rural areas is less than urban, but it is also raising, and this is a concern on management and affordability. So women's health are like to have better population health. So we need to concentrate more on women's health, because here diabetes begets diabetes, and to remain more productive for generations to come. So I think we had a great lecture before mine, and we had a lot of learning lessons, how to do it at field. And that's what is required for today, like increasing awareness, looking at this data, having an aggressive approach to manage and prevent prediabetes progressing to diabetes. So now we also have data to say you can even reverse diabetes. So why not prediabetes? I think that is where we all should come together and play this role so that we can prevent progression of prediabetes to diabetes, and if possible, prevent diabetes, prediabetes itself, looking at the adolescent girl, and possibly at that time, awareness, education is what's most important. Thank you very much for a patient hearing. I'll stop sharing.
Thank you, ma'am. Ma'am, can we take questions now or at the end of the three?
At the end of the three,
however you want to.
The end of the three.
Any questions are there, ma'am? Chat box, I think I'm unable to see.
Krishna Prashanti, why don't you take it at the end of the three?
Sure, ma'am. Sure. Okay. Now we are going to the another very important topic by the eminent speaker, Professor Dr. Neeta Deshpande from Belgaum. She is going to speak on obesity and pregnancy risk, a challenge bigger than what we imagine. And she is a diabetologist, bariatric physician, Belgaum Diabetes Center, and professor and HOD of Medicine, Dental College, Belgaum. She has given a very brief CV for all of you, but she is a great writer, scholar, and she is a very physically fit and a role model for all the obesity bariatric physicians, and she is an excellent lecturer, clinician, and researcher. Over to Dr. Neeta, ma'am.
Thank you, Dr. Prashanti, for that very, very glowing introduction. I'm really overwhelmed. Thank you so much. And thank you once again, Usha, for putting this wonderful extravaganza, academic extravaganza together yet again. Thanks so much for that. It's a fantastic program. So without much ado, let me start to share my screen. So I think it's visible. So the topic that has been given to me is about obesity and pregnancy risks, the challenge being bigger than we imagined. Now, what you see beneath about gestation, this is my very first slide, where gestational diabetes, preeclampsia, preterm labor, cesarean delivery. We know about these pregnancy risks, but this lecture is to highlight the fact that the challenge is far bigger than what you just see on the screen, because there's so much more to it. So many more risks are there. And we all know that more than one generation, in fact, 2 or 3 generations are going to be affected by this obesity and all the complications thereof. And that is what we are going to revisit and look at the extent of the risks that are actually involved when a pregnant woman is actually obese pre-gestationally. So this is in a nutshell actually about the effects of obesity on pregnancy. So if a woman is obese and she gets pregnant, what actually happens? So you can see here very well that this is an obese woman, and because of obesity, the fact is that she herself has a lifetime cardiovascular disease risk, and the fact that she's going to have pregnancy complications. But apart from that, there is going to be vascular injury, which can again lead to preeclampsia. Of course, there's insulin resistance on account of the obesity, which we know can lead to gestational diabetes. And the hyperglycemia per se, if there is gestational diabetes, can lead to macrosomia, childhood obesity, and cardiovascular disease. So you can see very well here that obesity has multiple effects on pregnancy in a woman. And this is just in a nutshell, but there is really far more to it than that. So we all know over here, this very nicely tells you that there is programming of metabolism, adiposity, and cardiometabolic risk factors when there is maternal obesity. So all these changes occur across the pregnancy, both all in early development. There are changes in the placenta, and there is neonatal programming, which is going to affect the next generation. And this is right, as I said, from the early development. And when there is weight gain, the diet quality also, of course, matters. But when there is weight gain, there are epigenetic changes which occur. There is programming of stem cells. There is inflammation, lipotoxicity. There is a change in the microbiome, which is again very, very important for future obesity, future other non-communicable diseases. There will be an implication for the milk composition as well. So you can see here that maternal obesity has effects at multiple levels, which we couldn't even have imagined. And they are ultimately going to lead to problems for the mother, of course, which we already know, but for the child as well. So if you look at this nice diagram, this is what is going to happen in early pregnancy. So you have the pancreas here. This is an obese woman. And in early pregnancy, because of obesity and hyperinsulinemia, there is excessive amount of insulin that is going into the placental and fetal side. And the placenta is going to become bigger. There are more nutrients going into the baby, causing macrosomia. Then there is decreased insulin sensitivity, and this is again going to form a circle like this. There's excess amount of nutrients because of fatty liver in the mother. The fat cell is expanded. The skeletal muscle also has fat, and excessive amount of nutrients going into the baby, causing macrosomia, as you can very well see. So this again very well exemplifies what happens when there is maternal obesity associated with pregnancy. Now, the next two slides, I'm just going to give you a snapshot first and then go into the details of exactly what happens when a pregnant woman is obese. So the risk of pregnancy complications, we all know, one is miscarriage, which can become recurrent, and then it's about stillbirth. So obese pregnant women are 40% more likely to experience stillbirth compared with non-obese pregnant women, where the hazards ratio is 1.4. And the risk, unfortunately, directly increases with rising body mass index. So the more obese a woman is, the more likelihood that she is going to experience stillbirth. That is an important thing, and this study is there which tells us about this particular thing. Then, of course, we all know that obese women are more likely to have gestational diabetes, and then preeclampsia and gestational hypertension, again, are very, very important things that can happen along with this particular problem. Next is cardiac dysfunction. I'm going to tell you a little more in detail about what happens with cardiac dysfunction. Sleep apnea. So obese people or obese women are anyways more likely to have obstructive sleep apnea, and this risk increases when there is pregnancy. Proteinuria, NAFLD. So there is more weight gain, again more chance of NAFLD. And then again, as we all know, there is an increasing need for a C-section, and the risk of C-section complications added to that, like wound infections. So overall, these are the risks of obesity in a pregnant woman. Venous thromboembolism, which I'm going to also go into a little more in detail. And all these comorbidities which are there, Many of them can be present individually, or they may be part of an insulin resistance complex. So you must all understand that most obese women have insulin resistance. So all these comorbidities that I talked to you about in the previous slide can be there individually, or they can be part of that entire complex. And the increased insulin resistance that is normal during pregnancy, we all know that basically insulin is a situation where there's insulin resistance because of human placental hormone. So this may cause pre-existing but subclinical cardiometabolic dysfunction to emerge. So when there is insulin resistance, as it is in a pregnancy, compounded by obesity, it can all get magnified to cause cardiometabolic dysfunction, and this will manifest as preeclampsia, gestational diabetes, obstructive sleep apnea, and all of this can be a syndromic issue. So let's come to preeclampsia. So there has been a nice systematic review of 13 cohort studies that involved about 1.4 million women, and the risk of preeclampsia doubled with each 5 to 7 kg or BMI points in pre-pregnancy BMI. So you can see, even in the previous, I talked to you about stillbirths. Again, there is a correlation with the degree of BMI. When it comes to preeclampsia, again, there is a correlation with the degree of obesity. So this relationship that I'm talking about, that is relationship of the risk for preeclampsia with increasing BMI, this relationship persists even after adjustment for other confounders such as chronic hypertension, diabetes, or multiple gestations. So it's very important for us to understand that the heavier a woman is, the more the chances of getting preeclampsia in pregnancy. Then comes gestational diabetes. Enough is said about gestational diabetes. We all know so much about it, but we know that the prevalence of gestational diabetes is significantly higher in obese women. And that is very, very intuitive, because we know that there is insulin resistance as it is, obesity compounds it, and that leads to gestational diabetes. So it is very much higher, and the risk rises expectedly with increasing maternal weight and BMI, with the odds ratio being quite high, which is 2.8. So everything is related again to the severity of obesity. So that has implications for management. That is very, very important. So what about the delivery risks? So an obese woman gets pregnant, there are pregnancy problems. What about delivery? So you have problems like preterm delivery, because obesity increases the risk of medically indicated preterm delivery, primarily because of obesity-related maternal disorders. Then about induced preterm birth, there was a systematic review, and overweight and obese women were at increased risk of induced preterm birth compared with women of normal BMI. And again, this is correlating with the degree of obesity. And then the third one, so my topic is challenges beyond our imagination. So you can see here, it's not just gestational diabetes, preeclampsia. There are problems in delivery, preterm delivery, failed induction of labor is what you're seeing here. So this was a study that looked at the effect of maternal obesity on the rate of failed induction of labor. And this was again correlated with the obesity class. And you can see here that all these problems are more when there is obesity. Then coming to more complications during labor and delivery. So observational studies have shown that obese women were more likely than women with BMI less than 26 to have slower labor progression and fetal, and ultimately receive labor induction and oxytocin. So there is problem during labor as well and delivery. So women with obesity have an increased risk of vaginal delivery, which I've already shown you. Emergency cesarean section rates due to inadequacy of uterine contractions during labor is also higher in obese women than their normal weight counterparts. And finally, mothers with obesity who undergo cesarean are additionally at increased risk for anesthesia-related complications as well. There are higher rates of epidural failure, aspiration under general anesthesia, difficult intubation, post-op hypoxia, atelectasis, all associated with obesity. So as you can see, there is far more than what meets the eye with respect to obesity and pregnancy. There are a lot of complications that are associated with pregnancy, labor, delivery, etc. Now coming to the baby, maternal obesity and health risks to the baby. So all of these we know: congenital disorders, macrosomia, growth problems, asthma, childhood obesity. But let's look at some of these a little more in detail. So these are the odds ratios. So obesity in the mother and the risk for congenital anomalies. Mind you, it's just obesity. I'm not talking here about gestational diabetes. It's obesity and the increased risks. So you can see that neural tube defects, hydrocephaly, cardiovascular anomalies, orofacial anomalies like cleft lip and palate, limb reduction anomalies. If you look at the odds ratio, they're all increased: 1.8, 1.6, 1.3, etc. So just obesity also confers an increased risk for congenital anomalies. And unfortunately, in obese women, these very anomalies cannot be detected well enough as compared to a non-obese woman. So detection of congenital anomalies by ultrasonography is significantly reduced with increasing maternal BMI. So you can't just visualize it. So detection of anomalous fetuses decreases with increasing maternal BMI by at least 20% in obese women, which is really huge. So you can't even detect these in time in obese women. Added to that, the risk of all these is more, as I showed you in the last slide. Venous thromboembolism is a big problem. There are a lot of studies that talk about venous thromboembolism risk in obese pregnant women. It's a serious risk. So one study showed that up to 57% of women in the UK who died from venous thromboembolism during pregnancy were in the obese category. This is quite a high number, as you can see. There are, of course, predisposing factors to this, but again, all these predisposing factors are also related to obesity, such as preeclampsia, increased frequency of operative delivery. These all add to it, but then they are also related to obesity themselves. Then we have postpartum concerns, such as the odds ratios of postpartum venous thromboembolism in women with class 1 and as I told you earlier also. So postpartum venous thromboembolism is a huge problem. Then patients with preeclampsia, fetal growth restriction, infection, emergency cesarean section are again there at an increased risk for venous thromboembolism. And all of these are again related to obesity. Then comes lactation. So obese women are prone to difficulty with lactation as well. And we all know also that children of obese women have a predisposition to obesity later on in their life. And this is perpetuating the cycle, because this obese child is going to become an obese pregnant woman later on, and the cycle just continues. So the epigenetics also goes on, and even the phenotype also goes on, unless we do something about it. So this is to put everything in a nutshell. The risks associated with obesity during pregnancy as a conclusion, you can say. So on the maternal side, you have diabetes, hypertension, preeclampsia, venous thromboembolism, pelvic pain during late pregnancy, obstructive sleep apnea. I also told you about wound infection post-cesarean. Then postpartum complications such as weight retention, anemia, and of course, a lifetime risk of cardiovascular disease. And at birth, you're going to see increased rates of cesarean sections, failed trial of labor, which I already talked to you about, uterine rupture, maternal morbidity, and neonatal injury, probably on account of macrosomia as one of the reasons, is all seen during the birth. And the worst thing that we see is in the offspring, you can see birth defects. I already told you, you're not able to see them very well on ultrasound. Macrosomia, prematurity, which I already told you about, hypoglycemia, because after all, there is insulin resistance. So even if there is no gestational diabetes, the insulin resistance and hyperinsulinemia is going to cause hypoglycemia. I also talked to you about stillbirths and how the level of BMI is correlated linearly with the stillbirths. Neonatal intensive care admission, of course, then asthma, autism, And attention deficit hyperactivity disorders, ADHD, is also more common in offspring of obese pregnant women. And early development of metabolic diseases such as diabetes and hypertension in the offspring is also seen. So in a nutshell, you can see that these are all the risks associated with obesity during pregnancy. So the challenges are far more than we usually think, and the odds are very, very high that these are the risks that happen. So to conclude, women should receive counseling regarding potential pregnancy risks associated with obesity. And because of this, apart from this counseling, preconception weight loss must be advised, must be followed through. And in fact, I would say that pregnancy should be put on hold until a decent level of BMI is achieved, so that you can mitigate all the risks that I talked to you about, both in the mother as well as in the offspring. And the goal also, once the woman gets pregnant, an obese woman who gets pregnant, is to avoid excessive gestational weight gain. There are women who put on even up to 20 kgs during a single pregnancy, and they're already obese. So you can imagine all the risks that I talk about are going to be compounded. And these are common in obese women. So this was my last slide, and I hope I have been able to express very clearly all the challenges that we have, the unimaginable challenges that we have when we are dealing with an obese woman who gets pregnant, what happens to the child during birth and what happens to the mother. Thank you all very much.
Thank you, ma'am. Thank you for your wonderful lecture. Thank you, ma'am. Thank you. Thank you very much for your wonderful lecture as usual. Now we'll be moving on to the other topic. We'll be taking 3 sessions. The other important topic by another eminent speaker, Dr. Preeti Dabagado. She is going to speak on PCOS and pregnancy more than a fertility issue. She is a professor of endocrinology from SCPGA Lucknow. And I think these days we are more worried about PCOS. Every mother will be coming and asking about these issues and fertility issues. And we need to hear more about from Dr. Preeti. Over to you, ma'am.
Thank you for that kind introduction. And I should thank Dr. Usha for such a good academic feast. It's a privilege to be listening to such good speakers. And I'll just start sharing my screen. Give me a minute. Okay. So actually my talk has been made a bit easy by the 3 speakers when Dr. Jane Hurst spoke about that pregnancy is a window to all the NCDs which are about to come in the future. And then Dr. Dharmalingam speaking about pre-diabetes, and Dr. Deshpande talking about obesity, because I don't think we can dissect out very easily the effect of whether the effect of PCOS is just because of the PCOS phenotype or it is because of obesity. They are so intermingled. So my job is a little bit easier, trying to convince that after we have achieved fertility or conception, that's not the end of management of a woman with PCOS. I think there's a lot more to do to prevent future problems in the lady, as well as to prevent the transgenerational effect of PCOS in the future generations to come. So we all know that PCOS is a very common disorder affecting up to 8 to 13% of women in reproductive age groups, which is seen in different studies with the differences because of using different diagnostic criteria in this population. And we know that the etiology is a complex and a heterogeneous causes of leading to the PCOS phenotype. It's a interplay of genetic predisposition with neuroendocrine dysfunction leading to the GnRH pulsatility, leading to increased LH, obesity. Now there is role of edicts or the endocrine disruptors, with some people having a significant component of insulin resistance and metabolic syndrome. as well as the epigenetic phenomenon, which Dr. Deshpande also talked about. So the experts in this field actually would like to label it as syndrome XX, an extension of the metabolic syndrome, as Dr. Raymond taught us, as syndrome X. But probably this could be extended as syndrome XX in women. And it is an important feature to be kept in mind, addressed to in women who are pregnant. The commonly used criteria for diagnosis is the Rotterdam criteria, where we know that 2 out of the 3 features of oligoanovulation or amenorrhea with clinical or biochemical hyperandrogenism or the polycystic ovarian morphology, if any 2 of these are present, after excluding the secondary causes like hypothyroidism, hyperprolactinemia, androgen secreting tumors, then we can diagnose that a woman has PCO. The important thing to remember is that when you have this combination of 2 features out of the 3, you would have 4 different phenotypes where one of the 3 could be missing in the phenotypes B, C, and D. And in where the hyperandrogenism is absent, that is phenotype D, is the least affected. So most of the problems which you would see, or most of the metabolic features and the problems during pregnancy you would see in a PCO pregnant woman would be predominantly seen in women who have the phenotypes A, B, or C. We know that hyperandrogenism and insulin resistance resulting into hyperinsulinemia is the key or is a very important factor leading to the PCOS phenotype, as well as all the metabolic derangements in these women. I would talk about these transgenerational effects because of the associated hormonal and metabolic derangement subsequently. We know that the male and the female siblings or relatives of a PCO woman would have some or the other reproductive or metabolic phenotypes. Like men could have increased baldness and all the metabolic features like dyslipidemia, increased risk of diabetes. So there is a strong familial clustering of this phenotype or the PCOS phenotypes in the families. But when genetic studies have been done, only about 10% of this familial aggregation of the phenotype is attributed to these genetic loci. So why is the rest of the 60%? How does it have that much of familial aggregation? The important reason is that when a pregnant woman, a PCO pregnant woman, the fetus in utero is exposed to so many different hormonal and metabolic derangements, like increased androgens, increased anti-Mullerian hormone, or the insulin resistance, or the oxidative stress because of obesity, that there is a fetal programming which leads to changes in the fetus, and this phenotype is perpetuated, and you have effects which are seen in the, so this is the F0 generation, which is the mother who's the pregnant. This is the fetus whose F2 or the germ cells, in F1 is the fetus, and F2 are the germ cells of this fetus. Subsequently, this fetus is going to grow up into an adult and would have children. So you can see that the PCOS phenotype and the metabolic derangements are carried over from the F0 generation of the mother right up to at least the F3 generation. It has been very beautifully demonstrated in mice studies and dam studies. So we know that these effects and epigenetic phenomenon is a very well described and accepted pathophysiology for various NCDs leading to diseases in the next and the subsequent generations. So it is really important to identify PCO, identify that who's the woman at risk during the reproductive age, probably try to address these issues pre-conception, and maybe we may be able to mitigate the transmission into the subsequent generations. looking at women's health at this point of time, maybe we would be able to make some dent in the non-communicable diseases in the future generations. I just wanted to highlight that important aspect by this slide. The other important thing which we need to understand is that there are certain hormonal changes which occur in pregnancy. Initially, in the first trimester or about 12 to 14 weeks of pregnancy, the insulin sensitivity is reasonably maintained or good because it leads to increased accumulation of the required fuel for future growth of the fetus in the mother. Subsequently, as the pregnancy advances, because of the placental hormones being produced, the insulin resistance increases and the glucose levels rise during pregnancy so that the glucose is made available to the fetus. There is about a 70% increase in various androgens in the maternal blood, and they play an important role in maintenance of pregnancy, the duration of gestation, prevention of preterm labor, and actually initiation of parturition, onset of labor, as well as changes in the cervix or the cervical priming, which will help in a normal labor. So androgens have an important role during pregnancy and parturition. The fetus and the mother are prevented from this high level of androgens because of the placental aromatase, which neutralizes it and converts it into estrogen, so it does not have an effect. And AMH levels normally fall during pregnancy. By the third trimester, they are very low levels of AMH because there's no folliculogenesis happening in a pregnant woman. And after 4 to 5 days in the postpartum period, the AMH levels start to rise. This is what happens in a normal pregnancy. But as we know, the pathophysiology of PCOS is such that all these hormonal parameters are deranged. We have insulin resistance, so we have hyperinsulinemia, we have hyperandrogenemia. So all these androgen levels are increased, which may be, and the fetus may be exposed to this high androgen levels, as I showed in the previous slide. And maybe there may be fetal programming or the neuroendocrine dysfunction may set in, and it predisposes the fetus to, or a female fetus to have PCO, or the risk of PCO in a female offspring of a mother with PCO is higher. And AMH levels also increase exposure to this AMH levels in utero also have a similar effect. There is a very strong bidirectional relationship between PCO and adiposity. PCOS prevalence is in obese women, it is up to 40%. This could be an underestimate because women who are not so symptomatic or who don't have the extreme phenotype are unlikely to present to a physician or a clinician. But if you look at the clinic data or data from infertility centers, the prevalence of PCO in obese women is much higher. And with the rising obesity epidemic, probably this percentage will be even more. The other direction of adiposity in PCOS is that PCOS women per se have a tendency for excess weight gain. And the longitudinal gain of weight is much higher in women who have PCOS, and it happens at a greater pace. There are 3 or 4 beautiful cohorts who are being followed up for nearly 3 decades. One is a Dutch cohort, the other is a longitudinal Australian cohort, and a lot of this kind of a longitudinal follow-up data is available from these 2 major big cohorts, where they have looked at women who were born in 1972 and subsequently followed at various time points. They have had surveys and they have looked at the weight gain during the early childhood, the adolescent, the 3rd decade, and even at the 4th and 5th decade. And they have shown that women with PCO have a rapid weight gain and they have a difficulty in losing weight. This we can understand because of, not just because of the PCOS phenotype, but because of the associated mental and psychological problems these women may be undergoing because of their clinical hyperandrogenism or infertility, or just being obese, the level of anxiety and depression. All this may be affecting the ability to lose weight. And that is an important aspect which all of us who are directly or indirectly involved in management or looking after these women really need to understand this aspect about the mental and psychosocial health of these women. And probably it has to be addressed in a big way. And unfortunately, that aspect of management is grossly lacking in our clinics. And I think we need to push harder for this aspect of PCOS to be addressed in a better way. We know, as Dr. Deshpande told us, that obesity during pregnancy, but has lots of problems in the pregnant woman. So a obese woman or a increased BMI at conception, and most importantly, increased gestational weight gain. So if the weight gain is not according to what is recommended, then the problems during pregnancy are even higher. And unfortunately, again, women with PCOS actually fall into this category, that they have a higher BMI at conception and they tend to gain, the gestational weight gain is higher than as compared to non-PCOS women. So again, that puts them at a risk of having all those complications which we heard about in the previous lecture. As I said that PCO having hyperinsulinemia, insulin resistance, and hyperandrogenism puts the woman at a risk of having various metabolic derangements, right from glucose intolerance to dyslipidemia to hypertension, which eventually leads to higher cardiovascular disease. Obesity as well leads to the same risk. So dissecting the effect of obesity and PCO becomes very difficult in the various studies. And the kind of studies and the literature which is available for pregnancy outcomes or pregnancy problems in PCO, we have up to 7 or 8 years before these phenotypes were so categorized beautifully, or maybe up to a decade earlier. The PCO study groups were never characterized into these different phenotypes. So we could have a heterogeneous population of PCOS where we could have had women who didn't have hyperandrogenism. So probably they were less affected than the group who has all the three clinical characteristics of PCO. So if you have a heterogeneous group, the study effect or the outcome results in such population get diluted. So now all the international experts actually agree that when we are having PCOS study population or we are having a study on PCOS, it's always good to describe the various phenotypes and try to look at outcomes according to the phenotype. So we do understand logically even that various pregnancy problems or the complications during pregnancy in a PCOS woman would be higher as compared to non-PCOS women, but concrete and solid data, and the data is conflicting in each of these aspects. So what are the potential pregnancy complications which can occur in a patient, in a woman with PCO? As we heard, that spontaneous miscarriages, and here you would see that each and every supposed complication or the fetal problems, obesity is one important possible mechanism. So this is an important aspect which we should address prior to conception, as it is an important factor which can lead to various complications. Spontaneous miscarriages. This could be, earlier it was thought that it is because of LH hypersecretion, which leads to hyperandrogenism. But subsequent studies have shown that even if the LH levels are normal, still these women have spontaneous miscarriage. The odds ratio is about 1.9:2. This could be because of endothelial dysfunction, or the hyperandrogenism per se makes the endometrium not receptive for a conceptus. So this could be the reason for spontaneous miscarriage. Then coming to gestational diabetes, the risk is 2 to 4 higher as compared to non-PCOS women. This is independent of obesity, but it is exacerbated by it. Why do we think that this is independent of obesity? Because BMI matched, the prevalence of GDM in BMI matched PCOS and non-PCOS women, the risk is about 2.3, the odds ratio in one of the largest databases from unselected American population. The odds ratio is 2.3. And various studies have shown a 2 to 4 fold higher risk. And again, if the woman has a non-hyperandrogenic phenotype, the risk is not higher when the BMI is comparable. So again, we come back to that the phenotypes should be described. And as I said earlier, that gestational weight gain during any normal pregnancy as well as pregnancy in a PCO woman is an important risk factor, because in an unselected population from Australia, even if the BMI was higher at 15 weeks of gestation, the risk of GDM was not different if the early gestational weight gain was similar in both the groups, the PCO as well as the non-PCO group. Why are we talking about gestational diabetes? Dr. Usha has kept a full 2-day academic program on gestational diabetes. It is so important to understand that any metabolic derangement in a pregnant woman is the reason for the important concept of developmental origins of health and disease in adults. This is, what does that mean? That the fetal genetics or the fetal genome is affected by in utero effects because of the mother having any kind of a disease, or being exposed to any kind of stress, or being exposed to various environmental factors. The fetus is affected by all these factors. There is a change in the fetal genome because of DNA methylation, because of silencing of various genes, and it would lead to later in life various outcomes like increased autoimmune disorders, metabolic traits like insulin resistance, increased CVD risk, and neuropsychiatric traits. So this is an important concept which we need to understand as DOHAD. Same thing happens in the fetus of a pregnant woman who has GDM. Maternal and hence fetal hyperglycemia exposes this fetal genome, leading to either DNA methylation or silencing or histone modification, which alters the offspring's gene as well as expression and physiology, which would lead to increased risk of obesity and type 2 diabetes. So all these epigenetic phenomena do occur, and that is the reason why recognizing, screening, identifying all these factors, which probably we can modify to a certain extent, would decrease the burden of adult diseases in future generations. Coming to hypertensive disorders of pregnancy, like chronic hypertension, preeclampsia, eclampsia, these are the major cause of maternal morbidity and a risk factor for long-term cardiovascular risk. Prevalence in general population is 5 to 10%, but the risk is about threefold higher than non-PCOS women. And the risk factors which are associated are previous history of hypertensive disorders, chronic hypertension, or pre-existing type 2 diabetes, or multiple pregnancies. And the other is use of ART. Actually, use of various drugs during infertility or the duration of infertility does have an impact on various metabolic problems in PCO women who get pregnant. I think it is logical to understand because the duration of infertility or the longer the treatment probably is because of the maternal age would be advanced. Probably this phenotype is the severe phenotype where the woman is hyperandrogenic, or probably the woman has marked insulin resistance. So again, all these factors we already saw predisposed to the various metabolic derangements and problems during pregnancy. And the risk of hypertensive disorders is even higher, even after adjusting for the BMI. I talked about miscarriages earlier. Again, the fertility in miscarriages, also the fertility treatments and duration of infertility matter because probably the endometrium is not receptive or cannot carry the pregnancy to term. The other effects because of PCO could be that people consider as a high-risk pregnancy. So the chances of medicalized birth become more. But the problem with this data is that studies don't report clear indications why a section or a labor induction was done. So we need more studies to say that the reason for induction or reason for cesarean section was over and above obesity, GDM, or hypertension. Then only it could be said that the PCO made it a medicalized birth. As I said, that the PCO women, even during the antenatal period, have psychological issues, mental health problems like anxiety, depression, and it could be carried over during pregnancy and in the postpartum period. But does it adversely affect the pregnancy outcomes? Still, data and studies are lacking. Again, this issue needs to be addressed in well-designed studies. The fetal outcomes, the preterm delivery, the chances of preterm delivery are higher because of the associated metabolic problems, not because of PCO per se. So PCO is not an independent cause for having preterm delivery. IUGR, PCO is not known to affect the growth or impact or cause higher incidence of IUGR. But if there is associated hypertension or GDM, then the effect on the fetus is logical to understand. And ICU admissions, again, are because of the associated metabolic problems. So how can we actually address all these issues? I think it is important to have a good preconception care in addition to the regular care for any pregnant woman in the form of immunization, assessing the drug history, family history, preventive folic acid, and improving anemia and general health. Women with PCO planning for pregnancy need to have an OGTT prior to pregnancy. Probably we will pick up a pre-existing diabetes or impaired glucose tolerance or any abnormal glucose tolerance test, which we could address and decrease the risk further during pregnancy. Assessment during pregnancy, the diet during pregnancy, the stress during pregnancy is appropriate. And preconception weight management is an important aspect. BMI over more than 25%, a modest weight loss of even 5% helps in ovulation, and patients who are morbidly obese need to be advised bariatric surgery. And pregnancy should be avoided during pharmacological treatment and 1 year post bariatric surgery. This is an important thing which we need to remember. Metformin and pregnancy. Metformin is used in the pre-pregnancy period because of its advantage in improving the chances of ovulation and decreasing insulin resistance, probably helping in regularization of menstrual cycles. But continuation of metformin during pregnancy in a woman who's PCOS has not been associated with decrease in preeclampsia, miscarriage, not decrease, but continuation of metformin in pregnancy is not associated with preeclampsia, miscarriage, or any effect on birth weight. But the important thing we need to remember is that it does not prevent the development of gestational diabetes mellitus. But recently published study with use of metformin during pregnancy has shown that the offspring of women who took metformin during pregnancy, there is a long-term weight gain seen in these offspring. So the recommendation up till now is that once pregnancy is confirmed, metformin should be discontinued unless needed for any abnormal oral glucose tolerance test result. Either the woman has IFG or IGT, or the woman has diabetes. For that, metformin can be continued because it does not have a negative impact on a pregnant woman with abnormal GTT. Postpartum care, we should encourage for breastfeeding. We should encourage that the woman regains healthy, appropriate weight, and we should monitor the woman for future development of hypertension, glucose intolerance, and for the assessment of CVD risk. So the blood pressure should be monitored every year. If the oral glucose tolerance test is normal, it should be repeated every year, at least in our population, because we are at a high risk for developing diabetes. But in populations where the risk is low, it can be repeated every 3 years. In an unselected American population, increased CVD and psychiatric problem, the odds ratio was about 1.3 to 1.8 after adjusting for confounders. So we need to monitor these women for future development of cardiovascular disease. We should advise adequate contraception and to advise spacing of future pregnancies, because we don't want the woman to be overweight or has not gone back to her normal lifestyle, normal metabolism before she has a subsequent pregnancy. And as we know that PCOS has varied presentation across the lifespan, we are just addressing, at the moment, I'm just addressing this woman who is in the reproductive age group planning for a pregnancy. But we know that there are certain indicators or there are certain pointers which can be picked up early on as the baby is born. Suppose if the baby has IUGR or born SGA, probably having a gradual weight gain rather than having a rebound weight gain leading to adiposity, which will predispose for a PCO phenotype, that should be prevented. Premature puberty is an indication in certain populations for a future PCO phenotype. We pediatricians or people looking after children should be aware that proper or a gradual weight gain in newborns born as IUGR and SGA, picking up premature puberty or obese preschool child or an adolescent probably is a harbinger for PCOS later on in life. And if we address these issues early on, have proper lifestyle, have a proper weight or an appropriate weight, we could prevent potential complications during pregnancy in a woman who has PCOS. So to conclude, the pathophysiology of PCOS itself contributes to a high risk during pregnancy. I think we need to detect PCOS early on, even right from when the newborn or the child is born. Preventive health plays an important role in preventing the transgenerational effects in future generations.
Sorry to disturb you, ma'am. It's the time is getting.
Yeah. So we need to rethink. That's my last slide. We need to rethink treatment options which will decrease the risk of future complications. Thank you, and I apologize for overstepping by a few minutes. Thank you so much.
Sorry to disturb you, ma'am, but I think the next speakers are in the waiting. So thank you very much for your wonderful insights in this present topic. And any questions are there in the chat box?
I will answer
technology them. People can check any questions are there, or any face-to-face interaction is allowed, ma'am?
Of course, it's allowed. I mean, after each session, there are about 10 minutes for discussion. And I just wanted to say that all three speakers did such an amazing job, and there's a common thread: pre-diabetes, obesity, and PCOS, and probably all boils down to weight in a big way. So if there are any questions, I'm sure all the three speakers will be willing to take it.
Ma'am, can I suggest you one thing, that why can't we have a course on the separate specialty on the women's health? Not gynecology alone.
No,
I think all are getting overlapped now.
No, I mean, I think that's a great idea. Let's talk about it. And we have, actually, I have talked about it with a few of the Diwas groups already. So let's do that. I think that's a great idea. Thank you.
If there are no questions, can we wind up the session, ma'am?
Of course, it's up to you.
So I think I really congratulate all the three speakers for the excellent presentations, and very, very good insights were given. And we should thank all the delegates for their active participation in spite of the weekend and the forthcoming festivals, and still how much they are giving importance to our Diwas. And I really thank Dr. Usha Sriram Madam, a pan-Indian celebrity who is connecting globally also. So thank you very much for giving me the opportunity as a moderator. Over to the organizers.
Thank you so much. I was supposed to do a small presentation on Diva's 10th birthday, but the video is acting up, so it's going to be done tomorrow morning. So we can go straight to the next session. I think, is Smita Bhatt here? Okay, if Smita is not here, it's my pleasure to introduce the next two chairpersons. My absolute favorite, Professor Padma Menon, my dear old friend for many years, consultant endocrinologist at Jupiter Hospital, Thane, professor and head of medicine at LTMM Medical College. She was the head of the Department of Endocrinology at KEM, and so many wonderful endocrinologists have been trained by her. Thank you, Padma, for being here. Such an honor for us to have you. And Dr. Hepzibah, whom I just met this morning, is currently the HOD of OBGYN at Savita Medical College. She is a renowned teacher in Chennai, former superintendent of the Stanley Medical College and professor at Stanley Medical College. And as I mentioned, now at Savita University, again, someone who has takes a very active role in academics and the Indian Menopause Society, and was there with us this morning for the roundtable on GDM. Thank you, Hepzibah. So over to you.
Dear Usha, thank you very much for your introduction. First, happy birthday and congratulations to our Diwas. I'm very happy to be associated with you. And there have been very good sessions going on. It's almost like a complete revision for me for GDM for some time. So I call this session is concerned with thyroid disorders, autoimmunity and GDM, established and emerging consequences of GDM, and GDM and stress. The first speaker is Dr. Nitin Kapoor, MD, post-fellows from PhD, professor and head. Present affiliation is from the Department of Endocrinology and Diabetes Metabolism from Vellore. I would invite him to speak on thyroid disorders, autoimmunity and GDM, a condition where we don't know whether it is just both of them present because of it being two very, very common disorders, or whether it is it has something more to it. We will get some light thrown by Dr. Nitin Kapoor.
Thank you so much, ma'am. Thank you, ma'am, for that introduction. It's an honor and privilege to be here amongst such stalwarts, and heartiest congratulations to Dr. Usha, ma'am, and the entire team at Diwas for celebrating their 10th birthday. In the next 15 minutes or so, I shall take you through this topic of thyroid disorders, autoimmunity, and GDM. I will cover this very briefly with the help of 6 brief domains. And I think to get to this bigger picture of understanding what Dr. Padma ma'am said that whether it is just GDM and thyroid disorders coinciding because they are common or they have much more to it. And we'll see how things can be linked together to get to this bigger picture. And I would first start with a real life case study, a patient that I saw earlier this week, and something that is very, very common. So this is a story of a 28-year-old lady who's a staff nurse who came and saw me on Monday. She's been married for the last 4 years. She's had primary infertility before. She conceived with great difficulty with the help of artificial reproductive techniques. They spent a fortune to achieve this pregnancy, clearly a very precious pregnancy, something that we see often in our practice. But along with this, when she was diagnosed to have, when she was told to be pregnant at that time, she was also diagnosed to have hypothyroidism. And since the past 6 weeks, she's been on thyroxine. Currently, she's 22 weeks of gestation. This is a snapshot of her reports, and we clearly see that about 6 weeks ago, she had primary hypothyroidism. TSH was 13.4, clearly warranting treatment. Though she's been on treatment for the last 6 weeks, the recent TSH is normal. But at this point in time, she also seems to have GDM, which was diagnosed now. And GDM with hypothyroidism, first time both diagnosed during pregnancy, is something very common. Well, many times when we see these patients, they do have a lot of questions in their mind. And a part of these questions this patient did throw at me. She asked me, "Doctor, do I really need to take thyroid tablets?" And one more thing, doctor, we checked the thyroid levels during my IVF treatment and everything was normal. And now suddenly the TSH is very high. So, and you start a treatment for thyroid medicines for that. Further on, very concerned because yes, this is a precious pregnancy. She's been asking whether this will affect my pregnancy outcomes, whether it would affect my baby. And the most important question, that is my gestational diabetes, which have been diagnosed now, somehow linked to the thyroid that was diagnosed before, and whether it will go away after surgery. So I think these are common questions which are posed to us in clinical practice, which we need to answer, need to understand. And definitely, we are dealing with two of the most common endocrine disorders during pregnancies. Subclinical hypothyroidism per se could be seen in about 37% of women with pregnancy. To add to the complexity, if just talking of autoimmunity or looking at anti-TPO titers, about half of our patients would be having autoimmunity in the positive TPO titers, and about 10 to 12% have gestational diabetes or diabetes diagnosed first time during pregnancy. This is something which is really, really common. We get to see these patients with a lot of questions that they ask, and they need to know the answers. Well, is there an association between the two? And this is a paper which was published 2 years ago. And we clearly see that, yes, there seems to be some association between GDM and non-gestational diabetes, especially in terms of having at least a higher prevalence of subclinical hypothyroidism and the transient hyperthyroidism. So both of these seem to be higher in women who have, gestational diabetes. So yes, this is something which is very important for us to know. But before we jump into how we have to evaluate this, I thought it is important for us to look into the physiology of how this works out of the thyroid in pregnancy, and further when we look at it with the lens of GDM. So I think we all are well aware from our physiology knowledge that we have the hypothalamus pituitary thyroid axis, which is really very well regulated. We know the hypothalamus produces TRH, which regulates the function of pituitary gland. The thyrotrophs in particular here produce the TSH in response to the TRH secretion from there. And then there is a feedback inhibition from the thyroxine that is produced by the thyroid gland back to the hypothalamus and pituitary. Well, we also know that in patients with primary hypothyroidism, it's the thyroid gland which is really not doing the job properly. There is either an autoimmune destruction or whatever be the reason, the thyroid gland seems to be underperforming, which in turn increases the TSH and TRH. In primary hyperthyroidism, it's the overfunctional thyroid gland, which increases T4, and therefore has a reduced TSH and TRH. So yes, TSH seems to be the most convenient test, which really helps us to differentiate which thyroid disorder we are dealing with, and even this is true during pregnancy. So yes, TSH is really important, but what happens during pregnancy? How does this dynamic change? And we know that during pregnancy, it is the HCG, especially in the first trimester, that is secreted in large amounts. This HCG does seem to have a very similar structure with respect to the TSH, and therefore it tends to fool the TSH receptor, or in endocrine terms, we may call it as the specificity spillover. When there's a lot of HCG, it tends to act at the TSH receptor, makes that thyroid gland produce much more T4 than it should. And this increased T4 in turn will definitely go back to the hypothalamic pituitary axis that we just saw and reduce TSH. Well, not only this, we know the placenta also secretes a lot of estrogen during pregnancy, which in turn acts onto the liver, produces thyroid binding globulin, which in turn obviously increases the total T4. Not only this, there is increased GFR, there is increased iodine clearance. Ultimately, cutting a long story short, and there are several other things that are described based on the renal clearance of iodine, the oxygen consumption of the fetoplacental unit. But cutting a long story short, what really happens in pregnancy is elevated T4, is reduced TSH, is also increased HCG, which correlates very well with the elevated TSH, with the elevated T4. And the free T4 doesn't increase as much as the total T4, as you see as the red line. But yes, that also increases. So yes, during the pregnancy, the thyroid gland increases, and this does depend on the iodine sufficiency of an area. The total T4 does increase by 50%. Serum TSH levels reduce, especially in the first trimester. And what we as physicians should know is that the non-pregnant reference ranges are very different in pregnancy, and we need to make our patients reach the targets that are specific for pregnancy. Now, what happens to this thyroid physiology when we actually look at it through the lens of gestational diabetes and autoimmunity? Well, I think we all would agree and say that, yes, autoimmune thyroid disease is indeed the most common reason why patients develop hypothyroidism today. And presence of hypothyroidism with antibody positivity together seems to have an increased adverse outcome risk during pregnancy in terms of either miscarriages or gestational diabetes or premature delivery. So is autoimmunity the villain here? Well, when you look at literature, we know that in patients who are TPO negative, there seems to be a direct relationship between HCG and T4. And as HCG increases, for the reasons that we described in the previous section, we know that T4 tends to increase. But this does not seem to happen as well as we see in TPO negative women when we compare to those who are TPO positive. So yes, there seems to be a discordance between the association of HCG with total T4 when we are talking of TPO positive women. And therefore, it is probably the elevated HCG action does not happen as well in TPO positive women. And therefore, that could be one of the reasons why there is the role of autoimmunity, in addition to having problems with the thyroid gland, that adds on to complications of pregnancy. But what happens when there is GDM? So we've already talked of normal pregnancy. We've looked at how thyroid function changes within normal pregnancy. And then on top of that, autoimmune status, if it is positive, it has further complexity. Well, the matter is further complicated when we are talking of gestational diabetes. But I must confess that at this point in time, when we look at literature, and this is a brilliant review done earlier this year, and we still have a lot of data, but we still need to get more information to understand how to link all these data. So yes, we know that there are shared risk factors between a person who is developing gestational diabetes and gestational thyroid disease. Epidemiologically, we know that these are really common disorders. There seems to be a good pathophysiological link when we look at both of them, especially by looking at through autoimmunity, looking at through how hyperglycemia per se would affect the thyroid function, but also we know that the clinical consequences, and as a physician, I think this is more important for us, clinical consequences, not only for the mother, but even the postpartum implications are important. A simple diagram that sums all the effects of gestational diabetes and thyroid disease together. And we see that there are individual impact or individual disorders that are there. But yes, both preeclampsia and preterm delivery seem to be a common factor there, which does seem to be causing a problem. So yes, this is what we have as our big background knowledge. How do we manage our patients when we have patients with hypothyroidism during pregnancy, especially if they have GDM? Well, I must say that GDM doesn't really change the management of hypothyroidism. These were the earlier cutoffs, and now we know that TSH of less than 4 should be our target when we are treating patients with hypothyroidism during pregnancy. The Indian guidelines and papers talk about a little lower threshold. The bottom line is we are happy to give a little higher thyroxine, maintain a little lower TSH in pregnancy than in the non-pregnant state. Yes, we would like to monitor thyroid functions much more frequently, 4 to 6 weeks during the process of pregnancy, but also maintain T4 at least 1.5 times the upper limit of normal. So, well, that is there, but at the same time, when we do prescribe thyroxine during pregnancy, we must take into account what kind of doses we are giving. Instructions are very, very important, especially during pregnancy. Again, when our patients are taking iron and calcium tablets, how to space it out. And this is something important. So, well, there are several algorithms which have been published as to how to manage hypothyroidism during pregnancy. It's not very different when we talk of GDM as well. But yes, if it is normal, it's fine. If it is high, yes, we have our targets which are well defined. We need to monitor every month, give thyroxine. Not only this, after postpartum, we reduce the dose of thyroxine and recheck, say, about 6 to 8 weeks after delivery. Well, if it is borderline and the antibody status is positive, then again, it's a case-to-case basis. There wouldn't be a very straight, streamlined way. But is this for all women during pregnancy? Well, not at this point. Universal screening for thyroid is not what is mandated by the government. Yes, if you can do opportunistic screening is definitely the way forward. The American Thyroid Association gives us very clear as to where all we must ensure that our patients with pregnancy should be screened for their thyroid disorders, and type 1 diabetes is definitely a place where we have to. Why we have to treat or very appropriately treat thyroid disorders during pregnancy? We all know that it does not only has it mild effects during pregnancy, but also on the fetus, especially if they have grossly undertreated hypothyroidism. So yes, I think managing hypothyroidism doesn't really change as much during pregnancy. What about hyperthyroidism? And again, there's several causes of hyperthyroidism that happen during pregnancy, be it Graves' disease or thyroiditis that can happen, and very rare other causes. Gestational toxicosis definitely needs special mention. Again, with the same understanding that we saw earlier in the presentation, how the HCG tends to act at the TSH receptor. And when there is a lot of HCG, it can temporarily increase the T4 levels. But this does get to resolve as the HCG levels come down by 18 weeks, and then antithyroid medications with these patients can be avoided. But yes, if our patient has overt hyperthyroidism, it may warrant treatment because it does have a significant impact both on pregnancy and fetus. And we see that many of these problems that we are mentioning with hyperthyroidism are common to that what happens with gestational diabetes. And again, therefore, it's important to definitely treat this well while the patient has GDM as well. We ask for TSH receptor antibodies depending on indication. Again, if we really want to differentiate whether we are dealing with gestational toxicosis with Graves' disease, or if our patients have had complications previously, or women who are already on antithyroid drugs. So again, we see that in the presence of GDM, the management of hyperthyroidism doesn't really change. Since the topic is thyroid disorder, I thought to also very briefly mention about thyroid nodules during pregnancy. And again, if we found an cytology or an FNAC, which is indeed suspicious for malignancy, at that point in time, we do need to make sure that either our patient has anaplastic carcinoma, that's the only indication where immediate surgery is required. Otherwise, if our patient has nodal metastasis or a significant growth, the second trimester is the safe time. Otherwise, wait and watch, and surgery after postpartum state would be helpful. But again, when we talk of gestational diabetes with all these thyroid disorders and autoimmunity, I think at this point in time, what we know is, yes, both the disorders are commonly associated. We don't have enough literature at this point to say that one leads to the other, but yes, one can lead to opportunistic screening of the other. The management, as we saw, does not really change. But yes, as we need to know these different small aspects of thyroid disorders, I think at this point there is definitely more research required to tell us whether aggressively managing both gestational diabetes and thyroid disorders during pregnancy would lead to a better outcome, whether early detection of these two would again prevent development of their common complications that happen, and whether presence of these two problems during pregnancy have an impact on the mother and the fetus many years down the line. We still do not have any literature to support. So friends, with this, I would like to summarize what we've really spoken about, that gestational diabetes and gestational thyroid disease are common problems in the clinical practice. Many patients come with many questions that need to be addressed because of the common nature of both these disorders. It's important to know and understand the physiology of thyroid hormones during pregnancy and how autoimmunity, in addition, tends to add to the adverse outcomes. Both data, what is available in terms of shared risk factors, the epidemiological data, but also what we know today for sure is that the clinical consequences of both these disorders could be common and more if these are present coexistently. Management of hypothyroidism during pregnancy doesn't change during presence of gestational diabetes. It is quite streamlined. At the same time, the bottom line for managing hyperthyroidism would be probably undertreat more than overtreat. And again, a very clear outline for thyroid nodules. But what areas we do still need a lot of research and still need a lot of answers are, we still need to know the impact of therapeutic management of GDM and GTD together, how it's going to benefit our patient, how it's going to benefit the fetus during pregnancy, after pregnancy, and whether an early treatment would really be beneficial. At this point, the final line for this two disorders is that, yes, if you find one, you should probably screen for the other so that you can prevent the combined damage that happens. So I would stop here, but would be happy to take any questions.
Thank you, Dr. Nitin Kapoor, giving a complete overview of thyroid disorders in pregnancy. I have only one comment to make, and that is most of the time we screen for both. See, in US, they can say risk factors. Their insurance pays, here we pay. So patients who come at the age of 30 and 31, they want everything to be healthy. They are already late in pregnancy. So we do both diabetes screening as well as thyroid screening right when the time patient comes, just before pregnancy. When planning pregnancy, we start screening and treating them. I would now like to give over the mic to Professor Kiru Babani. Could you please take over?
Yeah, I should thank the Diwas organizer and Dr. Usha for giving me an opportunity to chair this session. And Dr. Nitin has given a very good brief over the thyroid and the GDM. And this is a very common thing we come across. Even in college days, we used to say, if one endocrine problem is there, look for another endocrine. That is true. We always do the screening, and you nicely explain the physiology and the importance of screening and how to do the management. And it was a wonderful thing to listen to you. Thank you so much, Doctor. Shall move on to the next. It's my proud privilege to introduce Dr. Chitra. She is Associate Professor of Endocrinology, Ramaya Medical College, Bangalore. And she's very much academically interested. And she will be talking to you, established an emerging consequence of GDM. Over to you, Dr. Chitra.
Thank you so much, Dr. Hepzibah. It's an absolute honor to be here today. And congratulations to Dr. Usha for allowing me to participate in this program. And it's an absolute honor. And I cannot believe that it has been 10 years since we started this journey. I distinctly recall us talking about this when you came to Kolkata to give one of the lectures in the RSSDI West Bengal event. I'm having some trouble sharing my screen. Can I please ask the host to allow me to share screen, please?
Ma'am, please try now.
Yeah. It still says host needs to activate.
Oh, it is activated. I'll make you co-host. Just try share now.
Okay. Should I log off and log back in?
Sure.
Can I ask Dr. Diwas to maybe move on to the next? I'm going to log back and log back in. I'm sorry about this.
I'll come back. My program is a little late. Can I suggest something in the interest of time? Can the next person talk first if that is ready?
Ma'am, are we moving on to the next lecture?
Is Dr. Ashlesha Bagadia available?
I'm not able to see her.
Yeah, I think because we were running a bit behind, she was going to join. Yeah. Stuti?
Yes, ma'am.
Is there a problem with?
I'm trying to coordinate with Dr. Chitra. I'll get back to you once she replies.
Let me message Dr. Bagadia also.
Okay, ma'am.
This is Dr. Usha. If you're available, you can join now because the previous speaker is having some difficulty.
Stuti?
Yes, ma'am.
I just spoke to Dr. Ashlesha and she's going to join right now.
Okay, okay, okay.
Yeah, she's joined. Thank you, Ashlesha. Yeah, Stuti? Stuti?
Yes, ma'am.
Dr. Ashlesha has joined.
Yeah,
So
yeah, yeah.
can you, yeah. So, Padma, do you want to go ahead and introduce Dr. Ashlesha? Okay, I can't hear. Hepzibah?
I'm just unmute. Dr. Ashlesha Bagadia is a perinatal psychiatrist and head of psychiatry at the Green Oak Initiative, which is a community mental health center at Chuguru. She leads a local perinatal mental health service called Chuguru Thrive to 5 and runs family therapy and group therapy program. She is going to talk about GDM and mental stress. All of us know how they feel when we tell them that they have GDM, to how stressed they become. So let's have some insight on that and how to manage that. Dr. Ashish.
Thank you so much. I'm going to share my screen. Can I just check if everyone can hear me clearly?
We can.
Okay, thank you. So I'm going to share, some insights which have come up from recent, studies. When I read the data, it didn't look like it was something new, but it's definitely supported by the evidence that is coming up now. And of course, I know one of the things that, as you introduced me, you said that when we reveal the diagnosis to the patients, how they feel. But I also wanted to expand on just the relationship between gestational diabetes and mental health. We know that there is an impact of stress, which can be a risk factor to develop gestational diabetes, to develop diabetes in general. And also, there is an impact of having the diagnosis or gestational diabetes itself causing stress. So what the studies were looking at is, what came first? Does the stress cause the GDM? Does the GDM lead to stress? What we found was it's a little bit of both. So in terms of correlation between anxiety, depression, I'm just going to talk about a little bit about the common mental disorders. The mental issues that you commonly see are mothers with history of anxiety, depression, or just getting anxious slightly and getting stressed. Now, there is enough evidence to say that women with gestational diabetes are more prone. So their tendency to become anxious or depressed, irrespective of just the not just from the diagnosis, but even otherwise, the tendency to have anxiety or depression is higher. And incidence of gestational diabetes in women who had anxiety and depression in pregnancy, their incidence of GDM also is higher. So the correlation is both ways. And what some studies are showing is that depressed women are more likely to develop GDM in the first trimester of pregnancy than those who are not depressed. And also just having this anxiety and depression, either due to other factors, even psychosocial stressors. We know that, women now who are living in more isolated, high pressure environments, they don't have that much time with their families because they are living in different cities. Their mothers who are supposed to come and look after them are themselves still working or themselves busy with other things. So the kind of support they had, or they're working continuously during pregnancy. So this external psychosocial factors may be causing the stress and anxiety, and that can impact in turn lead to increasing the risk of developing gestational diabetes. What some of the studies interestingly are showing is that negative emotions in pregnancy are also associated with higher blood sugar and more erratic control. Now we know, again, supported by evidence, that women who are anxious can fall into one of two categories. Either they are constantly seeking reassurance, constantly coming to the clinic and getting themselves checked a lot, or there is an avoidance of health services, avoidance of wanting to hear bad news or anything. They don't even want to. So either of these two extreme can happen. And when they have, say, gestational diabetes, which requires additional care, if the anxiety is a factor, then the care of that becomes erratic, which means monitoring of blood glucose can also become erratic. And depression in pregnancy can lead to, psychologically behaving in certain ways that can impact on how they view the pregnancy. So they may also become more pessimistic about blood sugar levels. Whatever I do, nothing's going to get better. Ye bhi hona tha. This also should have what happened to me. So they generally go into this pessimistic loop, which can make their care of diabetes harder. And now emerging studies are also showing that women with anxiety, depression, or just stress, exposure to stress, external or internal, can also increase HbA1c levels and can have an adverse effect. So, blood glucose can also be affected even if they immediately may not have gestational diabetes, which of course can impact on how the pregnancy progresses. Interesting studies are also now showing, and this again, I don't feel it's new information, and you might probably be able to tell me more about this, that women with anxiety, are the navigating their labor period is a little bit harder. But the studies now have specifically looked at, among the women with gestational diabetes, those with anxiety were compared to those without anxiety. And they found that with the diagnosis of GDM, those with anxiety were more likely to have higher rates of C-section and forceps delivery. And they felt that there was also a pathway linked to, impact on pain and anxiety leading to severe pain response. And them having navigated a pregnancy where they might have been anxious could have led to, how they respond to you during delivery. The one thing that, at least the systematic reviews are suggesting that is not being studied is how much of the BMI plays as a confounder. Because we know that, higher BMI, obesity, those are factors that affect, development of gestational diabetes. And those are sometimes factors that also decides the mode of delivery. So that is one thing that's not been studied. So we have to keep that in mind when we are looking at impact on the mode of delivery. And one big one, which all of you, will be looking at constantly for your mothers, is to have optimum maternal outcomes. And the mother and, of course, all of you and the pediatricians are looking at optimal infant outcomes. And again, now we have irrefutable evidence that, if there is gestational diabetes and presence of anxiety, depression, stress, unresolved psychological distress, then it has significantly lower neonatal weight, So already there is enough data to say that, just the presence of anxiety, depression, or any other psychiatric illness during pregnancy is directly correlated with low gestational weight, and neonatal weight is reduced. Small for age babies, IUGR is also linked. So if GDM is there on top of that, then that definitely can worsen the neonatal weight. Premature rupture of membranes, postpartum hemorrhage, postpartum infection risk also goes up. And apart from macrosomia, neonatal asphyxia, there is also an increased risk of neonatal hypoglycemia. Higher rates of preeclampsia, gestational hypertension, and preterm birth. And there are studies that are linking, in depression, the sort of vascular hypertension increases, and preeclampsia is linked with that as well. So the risk factors that you are diligently trying to reduce throughout the pregnancy, they slightly go up with the presence of gestational diabetes in combination with anxiety or depression. Of course, the risk of neonatal morbidity and mortality goes up, eventually leading to adverse neonatal outcomes. Now, this is significant for us also because we know that if this is the early exposure to the infant, then the infant's risk of developing emotional issues, being more fussy as a baby, and later on developing neurocognitive developmental disorders, and conduct disorders in childhood, and later adolescent disorders from a mental health point of view, those risks also increase. So that combination of untreated mental illness or stress during pregnancy in the presence of gestational diabetes can have a huge impact, and like a ripple effect. It's like a ripple effect that can go on. What you mentioned is a significant thing for our population. And I don't know if you've studied this enough in the Indian population. It's only, I feel, recently that the stigma against diabetes has gone down. And maybe my colleagues, you guys may be able to tell me better if it's really gone down or not. But just receiving the diagnosis of gestational diabetes itself can be very stressful. I know many women who I see who are, moving towards planning pregnancy. One of the things they're always worried about is, I don't want to get diabetes during pregnancy. So that's something that is there as, the anticipatory anxiety of it, then finding out that they have, and also now they get categorized as high-risk pregnancy. So that itself can lead to a lot of distress. For mothers who may have already got a depressed mental state or low self-esteem, there is a lot of self-blame. What have I done? I'm causing this harm to my baby. I've become diabetic. And if they are at least not thinking like that, then there are maybe family members who contribute to that, that you have done something, it's your fault. And that whole coming to the diagnosis of gestational diabetes itself can be a very stressful event, and ongoing, of course, throughout the pregnancy. One of the factors that is commonly seen with mothers who have anxiety during and get told gestational diabetes is a diagnosis, is that they start then worry that they won't be able to control their sugars well. Now they have to take extra care. How are they going to manage? And they may not be able to manage. They can't walk. They can't do all the things that is being suggested to them. So every time they can't do something that is being suggested, their anxiety goes up because they feel they're not going to be able to control something that has just happened to them. And of course, fear of developing further complications causes more anxiety. Another thing that also can happen for them, and which I have seen as well, is that if they have a hypoglycemic effect, episode, because of the erratic care or because of not really understanding how to manage, that itself makes them anxious. Especially for women who are now diagnosed for the first time, and experiencing a hypoglycemic episode for the first time, not being very savvy as to know what to do and not what to have around them, that itself can make them very anxious and can lead to, navigating the pregnancy in an anxious state. So just in terms of, the kind of patients we see, and when you encounter women with pre-existing mental illness, with or without their symptoms treated, I mean, if their symptoms are treated also, they bring a lot of risk factors with them into the pregnancy, which increases the risk of gestational diabetes, right? So, and this could be related to being on medication, which causes obesity, their lifestyle. They may not be very active, or they may have been depressed and not have any motivation. So their high cholesterol, blood lipids may be high. Their blood sugar may be high, but not yet developed diabetes. They may be smoking, unhealthy diet, very little exercise, and sleep disturbance. Stress, of course. So this risk factors, they're entering the pregnancy with a pre-existing mental illness. What was previously thought of, at least the older generation medication, they directly caused the metabolic syndrome and increased risk of diabetes. But recent studies are showing that the newer antipsychotics and newer antidepressants did not increase the risk of GDM. It's not the medication. The medication may perhaps cause a little bit of weight gain and contribute to the one risk factor of obesity, but the medication itself did not increase the risk of GDM. But what happens to our population sometimes is when they get the diagnosis of GDM, because they think medication would have contributed to it, or they may have been told by someone, they then stop taking the medication, even though they should have continued, even though it may not have been high risk during pregnancy. And then the cycle begins of what all I talked about. Their symptoms come up, and then they get more anxious, and then the diabetes is poorly managed. So the people with pre-existing mental illness can also be a challenge to look after during pregnancy, especially because they bring the risk factors, and if they develop GDM, then it's an additional difficulty for you. So what can we do? Of course, one of the main focus is to look at how the diagnosis is discussed with them. And what I've heard from my patients is, at the moment, they get very good care in terms of how the diagnosis is explained, that they understand, and generally the awareness about how, what they have to do is improved a lot. But what can happen is, if the patient has some anxiety or is not able to take that information, she may herself sabotage that process. She may not spend time to assimilate the information you're giving her. She may not cooperate with the care. And so for women who may have already got an identified anxiety or distress, or have other risk factors that you may be aware of, like, poor relationships in the family, not very supportive environment, financial stress. So if you know of other psychosocial stressors, then spending some more time and involving other people in comprehensive psychological intervention, even the first stage of explaining the diagnosis, enhancing their confidence, that we know this is now a very well understood condition, and we know we can help you, and you can look after yourself well during this time. So what you need is build their confidence in looking after themselves with the diagnosis of GDM. And for women who may already have a pre-existing mental illness, or may have had a past history of mental illness, or just stress, anxiety, they may not have sought any help, they may not have been on psychotropic medication, but just identifying that early, in asking about their mental health history, and looking at risk factors that are associated with high BMI. And there are now several screening tools available. What we have been doing is doing like a short course training obstetricians in perinatal mental health. So that gives an overview of, what are the ways in which you can screen when you have time, when you don't have time, because, it's impossible to do like a psychiatric history or even a mental health history in the short amount of time that they spend with you. So just picking up on some screening questions, asking them about their current mental health, how are they feeling right now? How are they navigating the distressing events in their life? Have they ever seen a mental health professional? Have they felt low long enough to feel like they want to isolate themselves from others? So just asking about their mental health and their emotional health, and also asking if they have people who can support them through that. So using screening, even when you're not when you don't see any anxiety, just using screening for mental health as a standard can be very helpful, because then you straight away start reducing the risks. And timely referral to a mental health professional. Again, this I'd be interested to hear if about other people's experiences in this, but it's a most difficult barrier, I feel, because even if you want to refer, I feel many people don't have access to the right professionals. And if you do, then it's fantastic, because that's a relationship we need to build. The problem we then hear that, obstetricians face is that they might refer, but the patients don't want to. There's still a lot of stigma attached, in which situation involving husbands, involving other caregivers, and explaining, the benefit of addressing the anxiety and depression. One of the most common worry for everyone, including clinicians and patients alike, is that if I see a psychiatrist or a mental health professional, then I'll be given medications that are going to be harmful. We now know that, there is a range of medication that actually the risk of taking the medication is much less compared to the risks that we just talked about. All the risks associated with that untreated anxiety, unresolved depressed state. And so what I have started doing, and I encourage others to do, is to not just focus on the side effect of the treatment, like side effect of the medication, but also the side effects of the untreated illness. If it's not taken care of, if it's not controlled, it affects you. It affects how your pregnancy is going to progress. It affects the infant as well. And so that conversation sometimes gets them, involved. And that need not be like a categorical conversation. It can be a conversation where you're involving them, getting them to ask questions, explaining what are the risks like. So the side effects of untreated illness, including anxiety and depression in them, can be very helpful. And that can also relieve them that, just like how they have gestational diabetes, they take the right care and they can have actually a healthy pregnancy and a healthy infant. The same way, if they look after their mental health, they can have a healthy pregnancy and a healthy infant. And they'll also enjoy their pregnancy despite having a combination of these two risk factors. So that's like an overview of what I wanted to say. Thank you very much.
Ashleisha, I have only one. The most compliant group of patients who come for treatment for this diabetes is gestational diabetes. Every other type 2 diabetes is not very compliant. Type 1 is not compliant. The minute it is their child who's going to matter. And my experience maximum is at KM Nair Sai Municipal Medical Colleges, where the people don't even have sufficient financial state. They'll do anything to take care of the baby. And that is something which I have seen. And if they don't have the other stresses, for example, financial stress, something, they do extremely well. Others are the most compliant patients I've seen for managing in gestation diabetes. If there's any questions, please ask her to continue. Are there any questions, please? If there are none, can we go to the next topic? The thing which we missed. Yes. You've been introduced, so may please start talking.
Ma'am, yes. Thank you so much. Apologize for the technical glitch. Absolute honor to be here. We'll spend the next few minutes talking about some of the established and some of the emerging consequences of GDM. I'm sure we've heard a bit of these mentioned in all different aspects of today's events. But I'm going to try and see if we can go through this. So I think everybody in this meeting who's logged in is kind of aware of the gravity of the situation, but it's specifically more relevant to our region because Southeast Asia records one of the highest prevalences of hyperglycemia in pregnancy, affecting close to 30% of all pregnant women. So that's how common this condition is. And many of the complications or consequences related to GDM, we've been uncovering probably much more clearly over the past 2 decades. And most of it have been specifically related to short-term complications related to the pregnancy and the mother. But we are also aware now that the mild hyperglycemia, which was considered fairly okay to have maybe 3 or 4 decades ago, could really be associated with significant complications or consequences to the offspring. And that has also been clear, primarily spearheaded by the findings of the HAPO study. But are there any other related consequences related to both the mother's health and the child health that we should be talking about? And that's probably the most important objective of this meeting. And I plan to touch upon some of the recent findings to highlight these two. So when we talk about consequences to the mother of the diagnosis of gestational diabetes, we clearly know that it increases the risk of pre-diabetes and diabetes significantly higher. Dr. Ashlesha did tell us that a diagnosis of stress, depression, and anxiety are more likely to occur. But could it also mean that there is an increased risk of other metabolic conditions, like, for example, non-alcoholic steatohepatitis or metabolic syndrome-associated fatty liver disease? Could it also be related to cardiovascular disease? So we'll first start with the lowest hanging fruit, the chances of getting type 2 diabetes after you've had a diagnosis of GDM. And I think this is like a fairly clear evidence that irrespective of which population you're looking at, the risk of type 2 diabetes increases significantly. The most significant data is this, which comes from our part of the world, recently published, to show that irrespective of what BMI you're looking at, we spoke about how obesity is a confounder and all of the other associated consequences we're speaking about. But irrespective of the BMI, if you broke women up into normal, overweight, and obese, the risk of developing type 2 diabetes progressively increases throughout age. It increases very early, maybe up as early as 2 to 3 years after the diagnosis of GDM, but it's a steep rise right up till your 60s and 70s. And that is also something that we need to be clearly careful about, because just the diagnosis of diabetes in women significantly pushes up the mortality rates in women as compared to men. And this is not just an economic or a cultural factor. There's a global increase in mortality in women with diabetes as compared to men with diabetes. So there has to be something physiological, something related to the way the disease pans out in women. And probably the most distinct difference is the fact that the presence of diabetes in women significantly increases their odds of having any kind of vascular disease, both micro and macro. While the world has been under the shroud that estrogen protects women from cardiovascular disease, the diagnosis of diabetes probably brings them out of that protection and increases their risk. And this, I think, is an extremely important conversation to have, reconsider, unlearn what we've known previously, and then act on it. This is data from the UK Biobank study. It's a large follow-up study happening of close to 5 lakh women in the UK. It is a charity event. There's data collected over years. What they've done is they took women with past history of GDM and women without past history of GDM and took a look at where they are at now, a few decades since the diagnosis of diabetes. And this is what they found. The red bars represent women who've had a history of GDM, and the blue bars, women without GDM. And when they looked at prevalence of diabetes, hypertension, or dyslipidemia, all of them were significantly increased in women who had a past history of GDM. And the risk factor rises right from their 40s, but it progressively increases even up to their 60s and 70s. So if you're trying to look at what causes cardiovascular disease to increase in women, probably these 3 are the predominant risk factors which upset your risk for cardiovascular disease. So if there's one simple takeaway for all physicians, obstetricians, ask for a history of GDM and let your screening be more intensive in this extremely high-risk women, not just for diabetes, but also for other cardiovascular risk factors like hypertension and dyslipidemia. And the same study went on to show that all different forms of cardiovascular disease, stroke, coronary artery disease, MI, peripheral artery disease, all of it was significantly increased in the group who had a history of GDM by itself. Similar reviews and meta-analysis showing that the risk of cardiovascular disease increases by about 1.56 is the hazard ratio for a future event in women who've had a history of GDM. And if you try and now look into all the factors which contribute to an increased cardiovascular disease, we are now beginning to speak about sex-specific cardiovascular risk factors. So we do know that hypertension, diabetes are risk factors, but if you're looking at women, not just GDM, also the presence of PIH or hypertensive disorder during pregnancy, presence of a history of a small for gestational age history in the mother is a cardiovascular risk factor. Early menopause is a cardiovascular risk factor. And it's time that we started factoring these non-traditional risk factors when we are screening women and trying to optimize their cardiovascular health. There is also evidence to suggest that presence of GDM does increase risk for long-term maternal renal disease, irrespective of whether there is a hypertension or not, and the risk increases with every pregnancy where GDM is diagnosed. Now, NAFLD is a sexually dimorphic disorder. It plays out differently. Overall, the prevalence of non-alcoholic fatty liver disease is slightly more common in men than in women. The onset of menopause seems to accelerate the risk of fibrosis. That is very important. But the diagnosis of GDM seems to kind of again increase the risk of non-alcoholic fatty liver disease in women by about twofolds. This is extremely recent information and data. We now know that all the guidelines which talk about management of comprehensively managing diabetes talk about screening for this important consequence of type 2 diabetes. The presence of a history of GDM significantly increases your risk of non-alcoholic fatty liver disease. It is not uncommon to find women in their 30s and 40s showing features of steatohepatitis. And it's also not uncommon in clinical practice in India today to note 1 or 2 women who develop even end-stage liver disease as early as 40s. And we do quite a few women in their 50s who have end-stage liver disease. So this is also something that we probably need to talk about screening more frequently and addressing management of this. Similar meta-analysis. And probably it makes sense to screen for this even before they plan their second or third pregnancy, because we do know that not just does it affect the mother's risk of having end-stage liver disease or pregnancy-related liver conditions like HELLP syndrome, also increases the mother's chance of eclampsia and the child's chance of a preterm birth. We've had Dr. Ashlesha talk about mental health. We do see that in women with GDM, there's an increased risk of anxiety and depression. But why should we as physicians care about this? Because a diagnosis of mental health illness in a group of women increases the risk of all metabolic conditions. This is fairly well established. The reasons can be many. It could be just the fact that they probably struggle to have self-care routines in place. It could have something to do with dysregulated autonomic syndromes, autonomic systems, if you are continuously anxious or not feeling your best. But the coexistence of depression in diabetes significantly increases mortality in women. And this is clearly established. This is data from the Nurses' Health Study published many years ago. But the rates are significantly increased when there is both diabetes and depression in women. So this is the sex-specific CV risk factors that I spoke about. We do know, and we should probably go back home knowing that GDM is a woman-specific CV risk factor in all women. And we don't just screen them for diabetes, we screen them for hypertension, obesity, NASH, smoking, depression, all of it. And that kind of becomes a routine in our lives. And retrospectively, when we are taking care of a woman who has diabetes, we factor in this and make sure that the care is comprehensive. What about the child? What are the consequences which are emerging for the health of a child? We do know that you could either have a baby who's too small or too big if born to a mother with GDM. But we also are very clearly aware of some of the consequences related to GDM in the child. One is the increased risk of obesity. 2, the increased risk of prediabetes and diabetes. But all of us are probably not very clearly convinced whether the new threshold of diagnosis of GDM, where you have one abnormal value of your blood sugar level, could that also possibly cause increased risk of obesity and prediabetes? And now we are sitting on solid evidence supporting this. So it has been close to 16, 17 years since the publication of the HAPO study findings. So which means the children are now aged somewhere in their teens. So this is data from one of those studies where they brought back children who were born to mothers who were diagnosed as GDM by the HAPO criteria. And they went on to do an anthropometric study. And you can see that the chances of a child being overweight or obese or having a waist circumference which is beyond normal for their age, all of it is increased in children who are born to mothers with GDM. Okay. But there's also now evidence to suggest that if you try and look at their blood glucose levels, there also seems to be emerging patterns of abnormalities in the children born to mothers who had a diagnosis of GDM, going by the HAPO criteria. So this is one such study. This was published recently, which took about 4,000 and odd children, called them back and looked at glucose data. I'm reiterating here that the categories which I'm going to show, the lowest category was less than 75, the 1R PPG was 105, and the 2R was less than 90. Values as low as this. And this is the pattern in which the glucose panned out after the children were called in and subjected to a glucose tolerance test. So you can see here that there are spikes in the postprandial blood sugar levels across categories, rising up even as low as the first category, which is a fasting closer to 75 milligrams. So there's also indications to show that there is a drop in the insulin sensitivity or glucose disposition index. So essentially, to conclude that presence of a history of GDM in the mother seems to show changes related to glucose metabolism and insulin sensitivity as early as 10 to 11 years in children born to these mothers at values which are considered abnormal according to the HAPO study diagnosis, which essentially reiterates that we are not overdiagnosing GDM, that we are not over-medicalizing pregnancy with diagnosis of GDM. So these are consequences which are truly adult diseases which have a fetal origin. There is also some evidence to suggest that presence of a history of GDM in the mother could increase the risk of respiratory illness in offsprings. But primarily the most important consequence of GDM in the mother is the fact that we could potentially increase the child's risk for almost all of these metabolic disorders. There's strong evidence for obesity and dysglycemia. We'll probably need to follow up children to find out for the other risk factors as well. So this is how the life cycle works and how gestation diabetes causes these changes. There's also evidence to suggest that there could be significant changes with neurocognitive development or even predisposition to mental health illnesses in offsprings born to mothers with GDM. So quickly to summarize, while we are now fairly clearly convinced about the potential short-term complications of GDM, both to the mother and the offspring, it's important to acknowledge and pay attention to the evidence that has accrued over the last few years, that it does increase the risk of cardiovascular disease, cardiovascular risk factors to the mother, including non-alcoholic fatty liver disease and renal disease, all of which could potentially shrink the life expectancy and also the quality of life for a mother. And these are low-hanging fruits where we can screen and be more active and proactive in treatment and management. We also do know that the entire metabolic milieu of the baby is altered with the fact that the mother had gestational diabetes during pregnancy. So this was the St. Vincent's Declaration in 1989. So it was a group of people who came together when they were trying to decide the cutoffs for diagnosis of gestational diabetes. And the values were so different from the values that we're talking today. And they concluded that they would like to improve pregnancy outcomes of women with diabetes to the level of those in the non-diabetic population within 5 years. Probably it's time to have another declaration now to say that we would want to optimize not just the outcomes related to pregnancy, but also to overall health and cardiovascular risk for all the women who have a diagnosis of hypoglycemia made during their pregnancy. Congratulations to Diwas and Dr. Usha. And what a fantastic program. Absolute honor to be here.
Thank you, Chitra.
Thank you. Go ahead.
No, I just wanted to say that, I've been wanting, to look at women's health, not through the narrow reproductive lens, but as the whole woman. I think we can extend that to that we should stop looking at GDM as just as, glucose control during pregnancy and just as glucose, but as this larger thing as you have listed all the established and emerging consequences. And we just need to, have a more holistic approach to women with GDM. Thank you, Chitra. And thank you, Ashlesha. I think this is a topic that we have not included in any of the meetings before. And I think you've highlighted how important mental health is. And it's, kind of like you started with the chicken or the egg, bi-directional relationship. So, this is something, again, we need to focus on. So any questions? Guess it's been so clear. And so we can move on to, yeah, thank you, Padma, and thank you, Hepzibah.
No, thank you, Usha, and we'll be reading. Okay, I'll join you tomorrow. Okay.
Thank you. Thank you. We have saved the best for the last, as you can see. We have the Diwas oration by Professor Kaveri Dasgupta, whom I had the pleasure of meeting for the first time in the month of May in Greece. And immediately I knew that I had to invite her to our program. It was going to be a face-to-face program, and I was so looking forward to having Kaveri, having you in Chennai. And, we'll just have to wait for the next one, next opportunity. And Kaveri, Professor Dasgupta is going to speak about prevention of diabetes after GDM. And, interestingly, this is really the reason why this whole, interest in or attention to GDM actually happened, right? That the initial, diagnostic criteria and all of that following the women was all done because of the to identify women who would go on to develop, diabetes after a diagnosis of GDM during their pregnancy, or those women who had glucose intolerance, and to have this oration on prevention of diabetes after GDM, I think is very, very not only vital but timely. Can we have the introduction of Professor Dasgupta, please? So she's going to speak to us about, as I mentioned, prevention of diabetes. Professor of Medicine at McGill University, physician and researcher, Professor of Medicine at McGill University, Director of the Center for Outcomes Research and Evaluation at the Research Institute of the McGill University Health Center. Studies focus on the prevention and management of diabetes and its related complications in collaboration with her multidisciplinary team, including patient partners. And I think this is an aspect of GDM care we really are going to learn from you, Kaveri, and implement it here in India. She develops and tests strategies to enhance self-management support. As many, previous slide, please. Yeah, over many peer-reviewed publications and received, many research grants from leading organizations, the Heart and Stroke Foundation, Canadian Institute of Health Research, the Lawson Foundation, the Madavi Foundation, and Diabetes Canada, and multiple, awards to her credit. And many has been a mentor to many who have gone on to themselves become fantastic researchers and clinicians. Next slide. So, yeah, I added this.
You don't have to go through all of that, Usha, my goodness.
No, I just, I added this just to say that, this e-platform based step and weight monitoring, which I had the opportunity to listen to in Greece, or part of it. I was very, very impressed, and health coaching on health behavior changes in gestational diabetes. So thank you, Kaveri, for doing this, and welcome, and for joining so early from Montreal.
Oh, thank you so much. And I would have loved to have been there, but we'll try it another time. I'm going to share my screen, and such a joy to meet Usha, and I hopefully we'll meet many of you. So at Usha's request, I'm going to talk about prevention of diabetes after gestational diabetes. And I caught the last part of Chitra's talk, which looked fantastic, and I think really sort of sets the stage for the importance of diabetes and many other outcomes after gestational diabetes. I'm going to focus a lot on what we've been doing here in Montreal and in Canada. And I know there's been wonderful work done in India and elsewhere, but I suspect that's why Usha invited me to talk a bit about that, our experiences. And Usha mentioned the different funding agencies that we've been privileged to be funded by. I have no relevant conflicts of interest. So, when we talk about gestational diabetes, we're concerned about diabetes after pregnancy, and certainly we're aware of risks around the development of type 2 diabetes. In fact, that was a cornerstone of definitions for gestational diabetes. And there have been myriad meta-analyses that have demonstrated this. One of the more recent ones in BMJ, quoting a 10-fold higher risk of type 2 diabetes after a gestational diabetes diagnosis, the greatest risk being in the first 5 years after pregnancy. But it's good to remember, of course, that gestational diabetes also predicts the development of gestational diabetes in later pregnancies. And that's one of the things we do want to prevent. In a large cohort that we're studying now of women with 2 consecutive singleton pregnancies, we found about 40% go on to have gestational diabetes in the second pregnancy if they've had it in the first. Some other studies have had higher numbers, 72% in a German study, 83% in an Italian study, but certainly there's a risk. And interestingly, in places where there are higher rates of type 1 diabetes, which we think, of course, much more as a disease of insulin deficiency, there are actually, there's certainly an association between gestational diabetes and the development of type 1 diabetes, particularly in women who already have autoantibodies. If they develop gestational diabetes in pregnancy, that may be a flag for their risk of insulin deficiency, and so insulin resistance in pregnancy may push them over the edge ultimately in later years, so that they get gestational diabetes, it resolves, and then later on they manifest type 1. And so we see here just a little bit of a graphic, just to kind of anchor in our minds that diabetes is always a balance between your need for insulin and the resistance to insulin. Some people make less insulin. Some people have more insulin resistance, often exacerbated by extra weight or a lack of physical activity, which is a little bit unique to each person, but there are some overall levels that we recognize as being a health hazard. And it is on the side of addressing weight issues, lack of physical activity, and lack of opportunities to optimize diet, weight, and activity due to socioeconomic factors, due to competing priorities. These are all the things that we need to consider. Now, in terms of prevention of type 2 diabetes, we all know about these large clinical trials that were published in the early 2000s in a variety of countries that looked at health behavior change as a way of delaying or preventing the transition from prediabetes to diabetes. And a couple of them also looked at metformin. So the Finnish diabetes prevention study demonstrated with a health behavior change intervention, they could have a 58% reduction. It was similar for that type of strategy in the American diabetes prevention program. And they also demonstrated a 31% reduction with metformin treatment. And this would have been at around 4 years, 3 to 4 years median follow-up. The Chinese Daking study showed a 42% reduction, and the Indian diabetes prevention program showed a 28.5% reduction with the health behavior change intervention and a 26.4% reduction with metformin. Japanese diabetes prevention study, 67% reduction with behavior change. Some of the variation in the behavior change relates to how the programs were structured. Were they group? Were they larger in number? Because, the American diabetes prevention program had many sessions. So yes, you're going to higher dose, maybe more of an impact, but things that are more deliverable, like perhaps the Indian diabetes prevention program, you may see less, but it's still quite impressive. So the American Diabetes Prevention Program, one of the reasons it's interesting is that they did a sub-analysis in women who had had a previous pregnancy and stratified them based on whether or not they'd had gestational diabetes. So we'll remember that the interventions they looked at were a placebo arm that received written information and a once annual kind of health behavior change pep talk. Another arm that got metformin, 850 milligrams twice a day, as well as this information. And then the health behavior change arm, where they had specific goals of a 7% weight loss and 150 minute per week moderate to vigorous physical activity goal. And they had 16 counseling sessions over the first year and once a month over the next 4 years. And they really focused on relationships between the partner and coach so that it was a motivational kind of relationship. There was self-monitoring of weight and portions and heart rate. There were certain behaviors that they emphasized, smaller portion sizes, lower eating, using the stairs, lower fat cooking. They would talk about cues that could lead to unhealthy eating and how to address them. They developed strategies for eating out and how to not overconsume. They talked about what to do if you did fall off the wagon and gain more weight or weren't exercising, how to kind of come back and recover from that. They talked about practicing strategies for high pressure situations like parties and vacations where we all eat a bit more or are tempted to. They addressed stress management. They talked about maintaining motivation. And they had an option in some centers for supervised exercise a couple of weeks or a structured meal plan. So I present that just to give a flavor of the types of things they did. So what happened in the women with a previous pregnancy? So in the women with gestational diabetes at the end of a trial, so around 3 years follow-up, the health behavior change arm had a 50% reduction in incident diabetes, as did the metformin arm, interestingly. And with extended follow-up, so after the trial, without further intervention, at 10 years, the two arms still had some persistent lower rates of diabetes development compared to the intervention arm, even though they were no longer compared to the control arm, even though they were no longer receiving an intervention. So it was 35% lower in the behavioral change arm and 40% with metformin, actually roughly the same, a 10-year follow-up. In the women without gestational diabetes, they also had, a 49% lower diabetes incidence in the behavior change arm and 30% lower at 10 years, but they actually didn't have any important impact with metformin in the longer term follow-up, and in the shorter term follow-up, it was a 14% reduction. So this sort of illustrates the importance of insulin resistance in women who do develop gestational diabetes and how it may be approachable, certainly through health behavior change, which has been the focus of my research, but also through agents like metformin. But what about metformin? So we did a scoping review a few years ago where we just looked at what are the pharmacological interventions that could be considered for diabetes prevention in women of reproductive age. And really, there was nothing other than metformin that looked like it had sort of a safety profile that could be used. And I don't think that's changed. In terms of the metformin, so in the DPP, 69% took metformin, 73% persisted with placebo, and there was some gastrointestinal intolerance, not huge, but it was there, as all of us who use metformin in our practices know. But there have been some studies, cohort studies, that have suggested, for example, in studies of gestational diabetes treatment, that metformin women who are treated with metformin, their offspring may be larger at 9 years of age. So there's sort of concerns about maybe impacts on the offspring. And then more recent data from a clinical trial, the MIGHTY trial, that looked at insulin therapy during type 2 diabetes with or without metformin. They found the metformin-treated mums, there was less weight gain and they had better A1C and lower insulin requirement. But the offspring were a bit lighter, 200 grams. There was less macrosomia, but there was more small for gestational age offspring. So that was during pregnancy. After pregnancy, would anyone use it for diabetes prevention? I suspect, it's certainly an option. But many women after pregnancy ultimately do get pregnant again. So, is there an important risk of SGA? We need to understand that. Now, for health behavior change approaches, why is DPP not enough? Why can we not just walk away from that? Well, the women in DPP who had this history of gestational diabetes, they were at least 12 years actually after pregnancy. They averaged 12 years. And we know that the highest incidence of diabetes after pregnancy happens within 5 years. So we need action then. But that's a time when the children are at home, people are working, there are a lot of competing priorities. So we really need tailored approaches that are specific to context that will attract women. We had developed and tested some years ago, in collaboration with women who had had gestational diabetes, a strategy where it was in person after pregnancy. They could come if they were within 5 years of a gestational diabetes pregnancy. There were 4 or 5 in-person sessions, so not as many as some of these other programs, because the women said they couldn't do 16 sessions in a year. They didn't feel, but at the same time, at that period of time, they were not interested. They wanted to meet with other women, was what they told us. And so they had an hour of physical activity with an exercise trainer to discuss what kinds of activities they could integrate into their day-to-day life. And then they, at each session, would have an hour and a half with a dietitian where they would actually cook together with the dietitian and with their partners in a second iteration, because they talked about how important it was for their partners to be involved. And they talked about mindful eating, healthy plates, portion sizes, and they shared a meal afterwards. In between the sessions, they used pedometers, they received sort of motivational texts, and we had a study website with recipe ideas and examples of exercise and stress management. And they, the ones that attended really did have a good time. We did it in a very nice center. So you see them cooking together, exercising together. And this is Montreal, so a really huge ethnic diversity in our population. What we learned, though, is that it's difficult to recruit women after delivery. Certainly in the second study, we demonstrated that we sent letters to 902 women. We found 314 who expressed interest. Among them, there were 106 who met our eligibility criteria, which required some excess weight and no established diabetes. And ultimately, out of that 902, we enrolled 59 couples, 118 people. So you see how it kind of can drop quite a bit. Among these 118, 12.7% didn't attend any sessions. And then among the rest, we had really good uptake. So 75% of the moms attended at least 3 of the 5 sessions, 64% of the dads attended at least 3 of the 5 sessions. So we did publish these findings. If you're interested, you can look at the paper in cardiovascular diabetology. So for the moms who stayed in, they didn't lose weight, but they ate out less, they ordered in less, they consumed more fruits and vegetables, they completed more steps, and they had lower metrics like HOMA-IR for insulin resistance and lower blood pressure. So basically, if you can get women and couples in, it can work, but getting them in is challenging. And this was seen in an Australian study that you may have heard of, the MAGDA study led by Charlene O'Reilly. And in this study, they had 1 individual in 5 group sessions compared to usual care, moms who had gestational diabetes. They had specific goals, no more than 10% of energy from saturated fat, no more than 30% from fat, certain amount of fiber, 30 minutes of moderate to vigorous physical activity daily, which is usually walking, and at least a 5% weight reduction. And they followed them out to 1 year. Our study was a 6-month study. And I'm just going to go back there. And so they had the same challenges with recruitment. So they approached by mail or directly over 8,000. They wound up screening for eligibility a couple of thousand. They consented 828. They randomized 574. And what they found was that once they got them in, 34% didn't attend any sessions, 56% attended at least 1 session, and 10% attended all. Their weight loss, they did demonstrate somewhat less. It was 1 kilogram, but that kilogram often goes with other good health behavior changes in diet and activity. And there was a loss to follow up over a year, 27% in the intervention group and 21% in the control arm, mostly due to a subsequent pregnancy. They then looked at a telephone versus group delivered strategy, so 7 telephone sessions, and they found that 82% attended 80% of the sessions versus 38% in the group delivery program. And the flexibility of the phone delivery appeared to be an enabler. So barriers were childcare, scheduling to the group sessions. We had childcare in our program, so I guess they didn't have in theirs. And they demonstrated in the telephone delivered strategy a 2 kilogram weight loss versus a net 0.36 kilogram weight loss in this analysis. So one of the challenges, and so Dr. O'Reilly and I and a couple of our colleagues from Denmark, we looked at the literature in terms of, how do you achieve penetration into women at risk, and how do you enhance their participation? Because if we can't get across that hurdle, then the most beautiful intervention will not lead to anything. So we did a bit of a systematic review. We found 16 studies that had enough data for us to calculate penetration and participation. So penetration is the number of people that you manage to invite amongst everybody that is eligible in your target population, and participation is the number who enroll over the number invited. And so we saw that in the studies that reported on these parameters, there was 85 to 100% penetration, often more penetration if the process started during pregnancy. So even though you're trying to prevent diabetes after pregnancy, engaging and interacting during pregnancy seemed to be important. And there was 40% participation, again, with recruitment during or soon after pregnancy, during that face-to-face contact during gestational diabetes care, so that later on then they would come. Whereas it was under 15% participation if the intervention, if the recruitment occurred after pregnancy, or if it was a telephone-based recruitment strategy. So those are things to think about when we're developing programs. How should we evaluate strategies once we have a strategy, we're testing it out? We're not going to take every strategy and look long term to see if women have developed diabetes, because that's a big time lag. So if we really want to iteratively improve and test strategies, what do we look at? So So Charlene and I, with my master's student, Nancy Wu, and other colleagues, we used a core outcome set approach. So we tried to develop a core outcome set for diabetes after pregnancy interventions using this core outcome set methodology that I'll show you. So our goal was to figure out what is it that we need to think about measuring in our studies. So we conducted a systematic review to look at the different outcomes that investigators have looked at across the world when testing interventions for diabetes prevention after a gestational diabetes pregnancy. We met to discuss these outcomes. Then we conducted an international eDelphi survey, asking 3 groups of stakeholders to rank the importance of different outcomes. So there were researchers, there were health professionals, and an intersection of both, as well as women who had had gestational diabetes and who had been part of, it was largely people who had been part of our studies in Canada. And then we ranked these, we looked at endorsements, and we selected those with high endorsement, as well as some that the stakeholder group brought to our attention for further discussion. We considered some of those as well. So you can look at the paper if you want to see the nitty gritty of what we did. But we basically, what we learned from it is that there are different groups of outcomes we need to think about depending on how quickly we're doing our assessment. So irrespective of intervention timing, things that we may not look at or think about, we really need to look at our program delivery metrics, participation, how many people, what goals were set and achieved, were the targets and activities completed, was there engagement with the intervention components, and how can we change things? Did the women feel more able to address issues around their diet and weight and physical activity, so their self-efficacy, their motivation to change, the perceived barriers, their perceived risk, their knowledge of diabetes, other factors, what was their health literacy coming in and going out? What kinds of social supports did they bring in and develop? And then what were their behaviors? So did they have changes in physical activity, sedentary time, dietary intakes, which can be hard to measure, sleep quality, that was often brought up by the women when they ranked, the importance of outcomes, quality of life, and then measures of adiposity, weight. But those are not the only measures, because you can achieve change through physical activity and dietary change without a large change in adiposity, cardiometabolic measures, glycemia measures, and then an economic evaluation. Whereas later on, if you're looking within 5 years, you may look at diabetes development, you may look at gestational diabetes recurrence, you may look at other longer term impacts, and shorter term, you may be looking at things like breastfeeding uptake, attending postpartum diabetes screening testing, because this is all important in diabetes prevention. Currently, and as Usha mentioned, I'm leading a trial called Active Patient GDM, where we're indeed trying to interact with women during pregnancy. The focus here is on impact during pregnancy, learning from the importance of that piece. But that, I think, could be coupled with a continued intervention after pregnancy. So this is a feasibility trial that we're conducting across 4 Canadian cities. And we actually completed recruitment and intervention. So we're now looking at the data. And what we did was everybody got access to a website with information, motivational messages, video capsules, tools for health behavior issues, physical activity, diet. And then a quarter of the group was randomized to a STEP and gestational weight tracking strategy, where they track their physical activity with a Fitbit, they track their gestational weight gain with a scale. We receive that information and we developed algorithms and we send them recommendations, and they get some automated motivational messages. Another quarter doesn't get that, but they get weekly calls from a health coach just to encourage them to be active, to eat in a healthy way. And then the final group gets both. So we wanted to see how women engage with these strategies, how easy is it to recruit, to ultimately conduct a longer and larger trial where we'll look at outcomes like diabetes after pregnancy, offspring size status, incidence of large for gestational age offspring and small versus appropriate. And so the website, it has information about healthy eating. It has examples of distributing food according to the healthy plate. It has recipes, some from different people for different backgrounds, judging how much to eat, video capsules, women talking about their experiences with gestational diabetes, and what to do after pregnancy. Reasons to limit physical activity, so all kinds of things. And then the intervention, so the step, track, and target. So they wear their Fitbit, the information is uploaded. The first week target is based on a prior week where they measure. And every week we try to edge them up or at least maintain them if they haven't increased. Because for pregnant women, in fact, the target is the same as for the rest of us for 150 minutes of moderate to vigorous physical activity. Anybody who's been pregnant, like many of us have, know that that's tricky. But we want to keep them, if they're under, to try to at least maintain and hopefully to increase to a level of 7,000 to 10,000 steps per day. The gestational weight gain track. So our recommendations are based on the Institute of Medicine recommendations. We look at how much they've gained up until the GDM diagnosis, and then we divide the remaining permitted over the weeks that remain up to 37 weeks. Some women may have already gained as much as they should by those guidelines, and so we then recommend that they sort of try to maintain their weight. They get a weekly target. Obviously, they're followed. If their healthcare providers feel that there's any issue with respect to activity or limiting the gestational weight gain, they have to defer to that. But every week they have a target, which is the recommended minus actual to date divided by the weeks left to 37 weeks. And then the coach, that's my main research coordinator, Debbie Chan, but they receive phone calls and texts weekly, motivation, encouragement, and they're guided by the website content. And so we've recruited successfully 227 women, which was over our target. And actually withdrawal has only been about 15%. And recruitment was not nearly as hard as in the diabetes after pregnancy studies that I described that we have done. We have 189 who've completed interventions and questionnaires and 4 with some tasks pending. We did an early view, and many of the women that we interviewed found the tracking useful, the coaching useful. Much smaller proportion didn't enjoy the coaching or tracking. Sorry. Definitely people like step tracking more than weight tracking because nobody likes tracking their weight. But but in fact, 61% found the gestational weight gain tracking useful of that first group of 52. Sneak peek. So because we take women after a GDM diagnosis, the median is 6 weeks in the intervention so far, there's they register their steps more than 4 days a week for the median of 6 weeks, and their weight weekly, and they achieve 94% of the goal that we set for them on average, and they're also well within the midpoint of the range of gestational weight goals that we give them. So all that to say that, we have our plates full, so to speak, to figure out how best to help women with gestational diabetes prevent diabetes after pregnancy. When we say prevent diabetes after pregnancy, it's preventing another gestational diabetes diagnosis. It's preventing type 2 diabetes. In the longer term, it may be preventing diabetes in the offspring and obesity. And even for a small subset of women who have some autoimmunity and who might be more likely to develop type 1 than if they hadn't had gestational diabetes, perhaps these health behavior change interventions will help them. We did a large study some years ago with the health administrative data, and we demonstrated, that women with gestational diabetes or gestational hypertension at 10 years, they were 14 times as likely to develop diabetes as women who didn't have any GDM or gestational hypertension. If they had both, they were 36-fold more likely. If they had either gestational diabetes or gestational hypertension, they were twice as likely to develop hypertension. If they had both of those pregnancy-related conditions, they were 5.7 times more likely. And if they had either, 40% more likely to develop cardiovascular disease or to pass, and with both more than twofold. So they're really good reasons to prevent diabetes after pregnancy. And in doing so, we may prevent hypertension and ultimately prevent the development of cardiovascular disease and other adverse outcomes or undesirable outcomes. So preventable aspects of diabetes after pregnancy are related to insulin resistance, health behavior change, and metformin are potential strategies. There may be some increases in SGA with metformin. We don't know what the significance of that is. Health behavior change strategies in women after pregnancy have to be integrated into pathways of care. And we need to consider and evaluate penetration, participation, engagement behaviors when designing and testing strategies. And telephone and other forms of remote delivery, maybe in combination with face-to-face, as well as digital tracking tools, could increase feasibility of participation and engagement for many women. So thank you very much for your time. I want to thank there's just an incomplete list, but all my co-investigators, collaborators, students, and most importantly, my research team and research assistants. And thank you so much.
Wow. Thank you, Kaveri. That was awesome. Amazing. Thank you so much. Convention, dictates that there are no questions after an oration.
No.
But and after this, we have like an open house. If you can stick around,
Sure.
people may want to ask you something. So, and Jane is here. Jane is back. Anyone wants to ask any of the speakers any questions, now is the time. And we can have a discussion. And it's also open to the speakers to discuss. I'll get the ball rolling and I'll ask Kaveri a question. So you must have heard about the living study from India.
I may have heard some, but you can go ahead and describe it.
No, it's just that it was, I didn't want to bring it up because it's a negative study. So this is a study of, I want to say 1,500 women or maybe more. And then this was a lifestyle, coaching, study postpartum. And unfortunately, they did not, see change in the glucose tolerance in those who had the intensive lifestyle coaching versus the ones who didn't. And it was a bit of a bummer. And how do we do this? But then after speaking with some of the guys, I found out that this was kind of through the COVID time, and no one's going to be able to do any kind of physical activity, and everything was done online. So maybe that explains the findings. So what do you think?
I think for all of it, those of us who really believe in health behavior change, we always feel like we're like pushing a boulder up a hill kind of thing. And I think it's really worthwhile to deconstruct and understand what didn't go wrong. Because for sure, remote delivery can be useful, but COVID was so isolating for so many people. There's kind of a limit to how much remote people want. So I think context-specific challenges. The reason when we had done our initial focus groups for the first study I was telling you about, that would have been in the mid 2000s. And at that time, Facebook was a thing. And we even asked the women, would you like it all remotely delivered or some of it? And they said, no, we want to get together. But then the reality is it's hard, to come together. So I think a hybrid model is something to think about. And then I think really what comes out in a lot of work, including analyses that they've done in the UK of their diabetes prevention programs, is if they have a peer support component, it can make a big difference. So I would say, you know, the magic may be in figuring out the right combination of peer support, both virtually and maybe face-to-face when it's possible. Some virtual elements, definitely for the tracking, you know, I think that's really helpful. But if you can have moments where people get together, it's a little bit like we're doing in universities, you know, for a lot of things. Like you can't put all your efforts in remote, because if you never get together with anybody, it's hard to form a bond. But once you've formed a bond, then you can, you know, maybe kind of build on it. So I think this is going to be a space where we really need to get the, you know, the patient, the people themselves, the social scientists, the social media experts. Like this is going to be beyond, you know, healthcare providers and researchers to kind of find out what is that magic formula, and that not everybody's going to want the same thing. So we need to have options. We need to be able to say, like, I want to try this and this, and then if it doesn't work for me, I want to switch to something else. But we have to fund those options and have them. What do you think, Jane? I wish I'd heard your talk. I was probably sleeping.
No, thank you. Your talk was brilliant, Kaveri. It was really great. I mean, I agree that options need to be flexible, but the reflection I was having when you're talking is they seem quite individual centered or maybe couple centered for your intervention that you did, whilst actually often it's a kind of the society is not conducive, you know, the pressures to go back to work, or there's nowhere to exercise, or the food system is just not, they can't afford to eat, you know, healthy food and things. So I just wonder whether in your core outcome set, whether there was any discussion about that sort of wider thing rather than all just being sort of individual centric, you know, on the woman.
We did discuss that. And I think that's kind of the elephant in the room, isn't it? Because we can do all this stuff, and then there's the whole public policy piece. I wouldn't even say public health, like public policy. And I have like a lot of good friends and colleagues who, like, I think it's not an either or, it's both. But in an ideal world, the context is conducive, and then we come in and we catch the people that have kind of slipped through. But the way it is now, everybody's slipping through, and then what are we going to do? Like, you know, it's I totally agree. You know, it's easy to say be active and walk, and in some places it's feasible, like in Montreal you can walk. I mean, we can use that, it's safe, and you know, sidewalks might not be perfect, but they're not bad. But you know, I've been to Chennai many years ago. It seemed walkable more or less, but probably
there's no sidewalk.
What's that?
There is no sidewalk.
There's no sidewalk. See, so that's already like.
And I'm just kidding. The whole walkability thing, you know, that's an issue. And you know, probably. And Jane was with us this morning, and we had an awesome roundtable. And so the social determinants of health are playing a huge
big drivers.
The cultural norms, you know, socio-cultural norms playing a big part. You know, they may not allow the women to go out and walk.
What about on the roof, though? I remember in Kolkata, that was like the roof stuff was big. Yeah. If you have a roof, mind you, but
it's not too hot.
You know, I'm just thinking that this whole, you know, this very protective feeling, you know, which brings me to my next question to both of you is if we start the efforts, like let's say 6 to 12 weeks later, by which time the mom is a little bit, you know, gotten used to the baby and gotten the whole breastfeeding thing, you know, she does it well, or learned to do it well, and that the baby is okay, sleeping better. So is that a time we can start, or that's too late?
I don't think I'm not even sure if it's too late or too early. I mean, I think the thing is I think we have to engage them during. So during pregnancy, everybody's focused on the child. And so by stealth, they could improve things for themselves, mom, dad, other household members. So maybe there they will. So that's one piece. And then I think you have to continue the conversation so that when they're ready during that first year, they'll do something. But that 6 to 12 weeks, I mean, I remember, and this is 2 decades ago, and it's still a blur as to what happened. So I think that's the challenge is, so I think then if you think about a mom, and if I think as myself about a mom, you're feeling that's a bit of social isolation sometimes, or you're feeling alone. You have the baby, it's you and the baby. So if the carrot could be less, we're going to prevent diabetes, and more, we're going to connect with you and connect with other moms who have diabetes, and maybe we'll bring in a bit of childcare so you can have a bit of a break, and we're going to, you know, bring in a little bit of food that's healthy, and maybe let's do something together. Maybe it's a way of making that social community attractive somehow, you know, and then building from that. Because I think that the emotional needs at that point are a bit different. And then if they can buy into that group and feel a bond, then maybe they can work, you know, later in that first year. Yeah. I think, what do you think, Jane? Like, I think
yeah, no, I totally agree. And I wonder if in societies where, or regions of societies where you've got very high prevalence rates of gestational diabetes, like you do here in Chennai, you know, 20-25% of women, whether it should be something that's more targeted at everyone rather than singling out those with diabetes. Because I mean, actually what you're doing is just good lifestyle advice. I mean, just doing exercise, eating healthily. There's nothing here that's specific for diabetes, is there? Other than maybe telling them to have a glucose test, you know, once a year or something. But the rest of it, and that sort of, we heard about mental health before, how important that is. I mean, that's for all pregnant women, you know, have so many changes in their stages of life and mental. I just wonder, whether we should be just seeing it more as a healthy woman thing rather than, you know,
I think
we're just going to single out, pick out these women who, you know, and make them.
And that was exactly the comment. So I'm doing some work with our Northern Cree community. So we have in Canada Indigenous communities with a very high burden of type 2 diabetes, gestational diabetes. And so we're still in dialogue. We did a lot of focus groups and try to, you know, we have it's been a 7-year story so far, but that was one of the points that they all made, where initially we were talking about gestational diabetes, you know, 20% of women have gestational diabetes or more, like it's like 20 to 30%, but about half of people develop diabetes ultimately. So they said, well, why just gestational diabetes? And we said, all right. So, you know, it's been a little bit more community-based in thinking. And so the goal is to have a facilitator from the communities who will rally the women and any household members to different activities and kind of be that connector. So that's, you know, that's that person's role. But I agree completely. Like, depending on the incidence of gestational diabetes and diabetes, if it's higher, why would you target? If it's maybe lower, you know, okay, you know, targeting is reasonable. And we're probably getting to that point in many places. So, yeah.
And I think it's also, and you know, Subhashri is online. So she has worked with, you know, rural women. Subhashri, you want to, you know, comment on the, you know, beliefs and practice patterns?
Yeah, thanks, Usha. So, in fact, I was actually, when I was listening to you, Kaveri, my work has been in rural Bihar and in rural Tamil Nadu. So, so I was actually trying to think and kind of say, how is this intervention going to work with the communities that I work with, you know, and you know, and how do you actually contextualize something like this to to these kind of, you know, settings? And I completely agree with you know, the thing about larger public policy. I mean, I mean, you know, these are also communities that are extremely marginalized, that are, you know, there is food insecurity. I mean, forget, you know, nutrition. I mean, there's hunger and food insecurity. And then in those circumstances, then how do you then actually kind of, you know, start, I mean, give nutrition advice and then stop there, you know, or say healthy eating and then stop there. I mean, you will have to actually engage with larger public policy and, you know, public distribution systems and what comes out of there, etc. Right? And also then the whole question of, you know, it's not just availability of spaces to walk. It's also about social and social-cultural constraints to walk. You know? Women are not allowed to kind of, you know, just get out and go for a walk. I mean, that leisure is not something that women are women enjoy or even are even allowed. So in rural Tamil Nadu, we actually some time ago tried to set up walking groups because of women who could kind of, get into a group and walk to kind of, break that social taboo, or at least like you're not walking alone, you're not just taking off for a leisure activity, but you're going in a group somewhere. But it didn't actually take off very much. I mean, till it had a good facilitator who kind of, pushed the women. It worked for about a year or so, but it was not something that kind of, sustained beyond that period. So I think we really need to look at, very different kinds of interventions for different contexts. And I'm thinking about this whole, I don't know if you're aware of the, the participatory group, activities that were done in Nepal and then subsequently in India, also in Jharkhand, etc., where they brought women together as rural women in groups, which met periodically to, and then kind of looked at very hard outcomes like newborn survival, and so something like that is maybe worthwhile looking at both during pregnancy and also the point that you're making about what happens after pregnancy. So I think a lot of food for thought. I mean, as to it is a problem, and even I mean, while Tamil Nadu has something like 25%, Bihar is not far behind. I mean, it's about 10-12% there, and in another 10 years, it's going to be where Tamil Nadu is with far worse kind of outcomes, because the health system is just not equipped to deal with something that is so large. So I think we really need to start thinking now about what we kind of do when we how we actually prepare ourselves for something that is going to come not too in a not too far future.
So just to add, Subhashri, we're just completing a large lived experience study in women with diabetes, and from that study we are learning so much about not just awareness or not about their experience with diabetes, but also these kind of challenges that they're having about from a gender perspective, or from other, like you talked about, food security. And so we're going to start something with women with GDM, a lived experience study, those who are actually going through a pregnancy and those who have actually already delivered, to find out what challenges they've had. And some of the women who've had GDM and then gone on to have type 2 and who have talked to us, and they've all said that they didn't have the postpartum support they needed, both from the healthcare professionals and families. So I'm just thinking that those are all areas that we can work on.
I totally agree with Subhashri's comment about.
I just wanted to say,
Also,
Dr. Usha, just back from Bangladesh, and they have a wonderful program there, which is run by the Diabetes Society, where they take the help of the imams, give them 2 rupees per person to check the sugars. That's their incentive. And then those are taken through to the Diabetes Society, which is actually educating all the MBBS doctors. And the imam's wife is told to look after the women. So like Dr. Kaveri was saying that, the women act as the ambassadors. And so we are planning to bring that program to West Bengal, at least certain parts, to use a church, a mosque, and a temple, and carry out the program for detection. Just detection for now, and then focus on women with GDM later in the community.
Oh, that's amazing. I know that they were using the qazis for preconception care. I'm aware of that program where the couples had to go to the qazi and they got preconception care, which is again brilliant. But
because they take the marriage vows through the mosque, so they are taken for counseling, both husband and wife. And I think it's a brilliant program that they are doing, because it's to every society member that they're reaching out. And it's a parallel program to the government. So it runs parallelly and provides care for everybody, which I think we are sadly lacking in India. With Dr. Usha's trying her best for the women, but yes, we have to reach out to everybody.
Sri Lanka has they have a group called as obstetric public health, obstetric public health group. So, I mean, they specifically do the education and follow up of women with GDM. So, I mean, we just need a very innovative, smart program here.
In fact, doctors, now that I'm heading the church's program, I've been requesting the priests and the school principals to give out their spaces for walking for women, because in the morning the grounds are clear. I mean, the children are not there, or in the evening or in the afternoon. But we need to sensitize them, I think, request them for spaces for women. It's difficult to walk in the public parks because of different reasons,
Yeah.
So,
thank you, Mary.
Thank you, Doctor.
So, any other questions? Anything? Let me see if it's anything in the chat box. No.
I've got one last question for Kaveri. You mentioned the metformin story. What's your do you think there is a future for, in some people, a drug therapy? Some people who are pre-diabetes or very high risk. It's obviously never going to be a universal solution for everyone, but should we be considering that? Because this lifestyle is so hard, as we talk about. So many people are trying.
I mean, I have to say, I'm a physician and I'm so bloody anti-drug is the problem. But I that was one of the reasons we did that scoping review. I think we have to be flexible. We have to think what's our big goal, and I think there is a role, especially when there's a vast population. But I don't think it means that we not do the other things, because there's so much besides diabetes. So, the exercise and it remains important, and the healthy eating. But we do, if we do projections and it has to be an option. I think we have to sort of give that as an option, and then people can decide. And as far as, we can probably kind of collectively demarcate, what could be the elements of a health behavior change strategy that could work. And then depending on the community, as Mary said, that could be delivered through a church or mosque or temple, that could be delivered through a school, that could be delivered through another kind of a group. It doesn't have to be the same thing everywhere. But here in Canada, I'm having the existential crisis over, Ozempic versus health behavior change in established diabetes. And because some people really need it, but it's a cycle of commercialization and capitalism unbridled. I mean, this is what it is. So, it's just creating situations where people may be food secure, or they're in a food swamp, or they have no opportunity to be active or no time. And then they get and then they're being bombarded with, this unhealthy food and commercial, sort of pressure. And then you get diabetes and heart disease and gestational diabetes, and the solution is a drug, but you're going to pay for it. It is kind of ridiculous, but then there are individuals who are suffering in that, and you have to use the tools that are available. So I think these are the way I've reconciled it in my mind, because I'm doing work in diabetes remission, where we're doing actually a fairly intensive, that not the Cambridge meal plan, but kind of a low energy dietary support combined with supervised exercise, and we're targeting young adults, so type 2 diabetes, but they're 45 years or under. So the way I've stratified it in my head is, if you're under 45, I want to really try that health behavior change piece very hard, at least to give you a chance. If you're 45 or older, I get it. You've struggled. The complications could be down the road a bit more quickly. I think at that point, maybe thinking about the drugs is not a bad thing. So, I think we'll have to crack that, where are the decision points, and people have to be part of that dialogue. But it does seem a shame to not create societies where you don't even get there to begin with, and then, you could have other options. I don't know.
I just took a flight, Kaveri, from Coimbatore to Chennai. And what they gave me on that 40-minute flight was a cookie and a drink, paper boat drink, which I thought was healthy. It's pomegranate juice. And after finishing the whole thing, I looked at it, full of sugar.
Yeah.
And a cookie. So you're sitting on a flight, you're bored to death. So
Yeah.
and I didn't need that cookie or the drink, but I ate. I mean, I ate it. So,
but if someone puts it in front of you, of course you're
Yeah, we'll all do the same.
I'm gonna eat it.
Yeah.
And then you get off the flight. The only three, things that they have in the airport are Cookie Man, Sri Krishna sweets, and some choco bar, something. There's nothing healthy to eat. So I'm just saying.
So you have to constantly be thinking, right? And that's hard. We're not good
There's
at
a
that.
lot of work to be done. So
a lot of work. Yeah. The other thing I tell people is our food is so good. That's the problem too. So it's harder. And it is hard. And in my remission study so far, I can tell you the people of South Asian origin are having a harder time with that diet. Not all, but a harder time. Because we've got good options. I mean, it's, there's good food there. So that's part of the problem. So yeah, there's so many elements to this.
And food is the way we've learned to show, all our love and admiration and respect and everything. So, so that's also a problem. But thank you all for, making this 10th anniversary such a remarkable thing and a memorable day for us. Thank you so much. Thank you, Jane. Your presence this morning was amazing. I've been getting messages from all my colleagues that we should, have more of these programs. So I said, I'm getting Jane a permanent room.
Well, thank you for organizing it. I've learned so much today. It's been brilliant. It's just really brushed up, on so many areas of diabetes and thyroid, mental health, everything, obesity, PCOS. It's been fantastic. Wow. And yeah, you were like the icing on the cake, Mary. Your presentation was wonderful. Thank you.
I'm glad. I'm so sorry I missed all of it. Next time I want to hear. And if you've taped the other presentations, I'd love
everything. I'll share it with you. And thank you, Kaveri, and thanks everyone who joined today. And we've had hundreds of people online listening, and so this is amazing. Thank you so much. See you all soon. Yeah, thank you.
Bye.